And itself, it has two subtypes. We have the warty or basaloid type, and we have the keratinizing type. And then other types, histological types, include basal cell CA, melanoma, Paget's disease of the vulva, which can be an adenocarcinoma, that is carcinoma in situ, and it's usually low risk and accounts for 15% of occurs in 15% of the cases, and usually this is not the case in the other malignancies such as breast CA. You'll see that Paget's disease in breast CA is more common than Paget's disease in vulva CA. We can also have a Bartholin gland adenocarcinoma type under the histological classification. So, as we have said, squamous cell carcinoma is the most common, accounting for more than 80% of the cases. So this slide is meant to just highlight some of the differences between the two subtypes, the basaloid and the keratinizing type. As you can see, the keratinizing type is more common compared to the basaloid type, and keratinizing occurs mostly in the older women, while basaloid occurs in the younger women. And the precursor lesions in the basaloid type is the warty or basaloid vulvar intraepithelial neoplasia, while in keratinizing type is the lesion sclerosus differentiated VIN. And prognostically, the keratinizing type has a worse prognosis compared to the basaloid type. So,
sorry. Let me take you back to this slide.
Okay.
I think this is a very important slide, Dr. And especially when you talk about the risk factors, that is HPV related. So the HPV risk factor is mostly for the squamous cell histological type of vulval cancer. And of note is, so the squamous cell histological type is then divided into HPV and the non-HPV related. So when you talk about the keratinizing type that is affecting the older generation, most of the time is actually the HPV, non-HPV type. So that has to come out clearly, that HPV risk factor is mostly for the squamous type. But this is a very important slide, and this differentiation is very key. It actually guides you most of the time, knowing that this is HPV and being not HPV related. Okay.
Yes, thank you for that addition. So the first subtype, that is the basaloid type, is usually related to the HPV infection. Sorry, I think Dr. has corrected that. So it's the keratinizing type, which is mostly associated with the HPV infection, and then the...
No, sorry, Dr. I think whatever I said is the warty type is HPV, the older type is non-HPV. So the slide is clear.
Oh, okay, okay.
Yeah. So there is squamous cell divided into HPV and the non-HPV. The non-HPV is the warty type affecting the younger population, while the non-HPV is for the older population with a history of probably lichen sclerosis. So the slide is clear. Yeah.
All right.
Sorry if I wasn't clear.
All right, thank you. Yes. So that is basically what is brought out here, as Dr. has noted. The basaloid type is the HPV related and usually undifferentiated, while the keratinizing type is related to chronic inflammation, that is vulvar dystrophy or autoimmune processes. Yeah, so HPV is responsible for about 60% of the vulvar CA. Usually most implicated is, we had said earlier, is HPV 16 and 33 subtypes, accounting for 55%. So in terms of clinical presentation, the most common site of occurrence of this malignancy is labia majora, and the signs and symptoms of all histological types are usually similar. Most patients present with unifocal vulvar plaque, ulcer or mass on the labia majora, and can also occur in labia minora, perineum, clitoris, and mons pubis, but less frequently compared to the labia majora. In 10% of the cases, the lesions are usually extensive, and multifocal malignancies occur in 5% of the cases, and the vulvar and perineal skin surfaces, cervix and vagina, all these areas should be evaluated during the clinical management of the patient. Another important presentation is pruritus, which is a common complaint, and it usually mostly presents with an underlying vulvar dystrophy, including lichen sclerosus or squamous cell hyperplasia. Patients can also present with vulvar discharge or bleeding, dysuria, or an enlargement of the lymph nodes in the groin. But these symptoms, again, they are less frequently encountered. And if they are present, they are suggestive of an advanced disease stage. So the typical presentation in a patient with vulvar CA includes an intense pruritus, pervaginal bleeding, and discharge. So in terms of diagnosis, usually done mostly through visual inspection and biopsy. So inspection is the first thing that is performed. Its performance is based on vulvar complaints during the pelvic examination. And so the findings are suspicious for pre-invasive or invasive vulvar disease if there are pigmented areas on the vulva, and if the lesion are raised or fungating. So if you get these two presentations, then you suspect a pre-invasive or invasive vulvar CA. And then the biopsy of the lesion is the gold standard for diagnosis. So invasive squamous CA is the most common, the histologic subtype. There is no evidence of race differences, and often develops from the vulvar dystrophies and also from VIN, vulvar intraepithelial neoplasia. Can occur anywhere on the vulva, but 70% occurs in the labia majora, but can also occur in the labia minora, clitoris, or perineum, as we had alluded earlier. Pruritus is present in more than 50% of the cases, and in most cases, the delay of between 2 to 16 months or longer is usually the case before biopsy or referral. So clinically, invasive squamous cell CA presents with vulvar pruritus, which occurs several years before the actual cancer in 2/3 of the patients. Some patients may also have ulceration, pain, oozing of serous fluid, bleeding, and lymphadenopathy, especially involving the inguinal lymph nodes. So indications for excisional biopsy include so changes in skin surface area, change in elevation when the lesions become raised, thickened, or nodular. Also changes in color when the lesions are brown or black in color. Changes in the surface to smooth or scary or ulcerated surface, or changes in sensation to become itchy or tingling. Spread of invasive squamous cells here usually occurs through three major mechanisms, including local extension, hematogenous spread, and lymphatic spread. So the lymphatic spread is the most common, and it follows the lymphatic system of the vulva. So from the vulva, we have lymphatic spread to the femoral nodes, which is usually initially limited to the medial upper quadrant of the femoral group. And secondarily, from this initial spread might drain into the deep femoral group. The superficial inguinal nodes are the primary group because of the direct lymphatic connection to the vulva lymphatic system. And they serve as the sentinel lymph nodes. And the deep femorals are connected to the superficial inguinal nodes. So they serve as the secondary recipients. Investigations in this case, you'll do colposcopy in early disease. You will do biopsy and make it excisional biopsy if necessary. Pap smear is also important to rule out to determine the histological characteristics and differentiate it from cervical. From other malignancies in the female genital tract. And radiological imaging, including chest X-ray and pelvic X-ray, especially if there is bone metastasis, you have to do the pelvic X-ray. And labs, including CBC, renal function tests, liver function tests, and VDRL. And VDRL is done to rule out syphilis. You also do random blood sugar and HIV test. So
sorry, Dr. Maybe we can spend more time on the investigations.
Okay.
So this is very important, and the mainstay of diagnosing squamous cell vulval cancer is biopsy. So you need a histological diagnosis. And for those who have been able to pass through the screening room at Chandaria, so there are different ways of getting a biopsy. I don't know whether that will come out later, but we need an excisional biopsy. So when you have a mass on the vulva, like you said, the commonest place is the labia majora. You don't go in and remove the whole mass. First, you need to get a diagnosis by just getting a small piece of that. Okay, so biopsy is the mainstay of diagnosis. Go on.
All right, thank you. So staging, we'll go to staging of the squamous cell carcinoma. So there are 4 stages. And in stage 1, the tumor is confined to the vulva with or without involvement of the perineum, 2 centimeters or less in the greatest dimension. And in stage 1, there is no nodal metastasis. So this stage can be divided into 2, stage 1A and stage 1B. So in stage 1A, the lesions are 2 centimeters or less in size, confined to the vulva, perineum, and with stromal inversion, not greater than 1 millimeter deep. And there is no nodal metastasis, as we said. In stage 1B, the lesions are 2 centimeters in size or more, confined to the vulva or perineum with stromal inversion greater than 1 millimeter with no nodal metastasis. So basically, the difference between the 2 stages are that in stage 1A, it's less than 2 centimeters in size. In stage 1B, it's 2 centimeters or more. In stage 2, it's usually the tumor of any size with extension to adjacent perineal structures, or involvement of the lower third of the urethra or vagina, or anus with negative lymph node metastasis. So again, there is no nodal metastasis in the second stage. In the third stage, it's tumor of any size with or without involvement of the adjacent structures, and that includes the lower third of the vagina. Lower third of the urethra or vagina and the anus. And in this case, we have positive. We might have positive lymph nodes, nodal metastasis. So it can be divided into three. So we have stage 3A, stage 3B, and 3C. So stage 3A and 3B, each of them is subdivided into two. So we have 3A1 and B1, A1 and 2, and B1 and 2. So in A1, we have involvement of one lymph node equal to or more than 5 millimeters in size. And in 3A2, we have lymph node metastases with the lymph nodes being, one to two lymph nodes, which are less than 5 millimeters in size. And then in stage 3B1, we have two or more lymph node metastases equal to or more than 5. And in stage 3B2, 3 or more lymph node metastases, which are less than 5 millimeters. And in stage 3C, we have positive lymph node metastasis with extra capsular spread. In stage 4, it is divided into 4A and 4B. So in 4A, the tumor invades the upper 2/3 of the urethra and or the vagina, the bladder mucosa, rectal mucosa, the pelvic bone, and or the bilateral regional lymph nodes as well. In stage 4B, we have distant metastases, and this must include the pelvic lymph nodes. So those are the 4 stages of the squamous cell carcinoma. So in terms of treatment, we have various approaches to treatment. So the first one is in situ lesion, local excision of the lesions. The second approach is superficial invasive wide excision. That is for those squamous cells here, those which are less than 3 millimeters in full thickness. So the early disease, lateral and central locations, and advanced disease, we usually involve radical valvectomy with modifications depending on the extent of the invasion. Chemotherapy also plays a role in the treatment, and the most commonly used regimen are mitomycin C and 5-fluorouracil. Also, radiotherapy plays a role, and supportive treatment is given according to the clinical presentation of the patient. So, for example, if the patient comes with complaints of pain, you give pain management, analgesia for pain management, and so on. So you do supportive treatment, which varies from patient to patient. So the algorithm for management of vulvar CA is as depicted here. So the first thing to do is to look for signs and symptoms suggestive of vulvar cancer, and then perform a physical exam to to identify the lump, the ulcer, and identify the color change, thickening, and also perform a colposcopy, and then do a biopsy lesion for pathological review. And as Dr. has said, the most commonly used biopsy is the excisional biopsy. And then once you do that, you'll be able to diagnose the vulvar CA. So after diagnosis, you do staging. So in staging, you do various imaging. You can do chest X-ray, MRI, PET scan, or CT scan, or CT chest, to diagnose metastasis to the various parts of the body. So after doing staging, then the management approach will be based on that, on the stage, and the earlier conducted approaches, that is identification of signs and symptoms and physical examination. So if there is posterior midline lesion encroaching anus, such as such that a posterior extenteration would be necessary to clear disease, then you use neoadjuvant chemotherapy, and then perform surgery or common radiation, followed by surgery, and sometimes preceded by inguinal node dissection. If there is a midline lesion or lesion which is equal to or less than 2 centimeters from the midline, you do a modified radical valvectomy and with bilateral inguinal node dissection, with which is the area for involvement of the sentinel nodes, which we said mostly the sentinel nodes are the superficial inguinal lymph nodes. And then if there is a unilateral lesion more than 2 centimeters from the midline, you do a modified radical valvectomy plus an ipsilateral lymph nodes, and also do you also do dissection of the sentinel nodes. So sentinel nodes are the same as we said before, the superficial inguinal lymph nodes. So those are the two approaches, and in all the three cases, you perform radiation for close surgical margins, that is less than 8 millimeters of positive nodes. So that is the end of this first part of the presentation. So I invite Dr. to do any clarifications or additions.
Thank you, Dr. Nicholas. You're already a doctor to me, for that excellent presentation on vulval cancer. And I think the summary that you have on the last slide kind of summarizes everything that you've mentioned about vulval cancer. And just to highlight some of the things, so after you've done your staging and you've done a biopsy and confirmed that this is a vulval cancer, very important is to be able to tell the size of the lesion and the location of the lesion, like what you said. If it's a midline lesion, and when you say midline lesion or it's affecting midline structures in our case here is the urethra or the anal opening, where you think when you do your wide excision, you'll not be able to get good margins and you'll affect the quality of life of that patient. Because if you involve the anal opening, when you're trying to do your wide excision, then you need a patient to have a colostomy. So for such patients, you don't need to do surgery, you give them chemoradiation. Yeah. So you have to analyze the patient individually. So if it's a lesion away from the midline structures, less than 2 centimeters, then you do a wide excision and then you do inguinofemoral dissection. Just a comment on the sentinel node. The reason why in advanced areas they do sentinel nodes is because when you do lymph node dissection, it has its morbidity, yeah? One is you can have bleeding, you can have what we call lymphocyst formation, you can actually injure some nerves around there. So because of those morbidities, you can have wound break, you can have infection because of those morbidities that are associated with lymph node dissection. So in developed countries, they do what is called sentinel mapping. So a sentinel node is the first node that will receive the dye. When you inject the dye, which is a technetium 99 or the blue dye, it will, once you inject it, when you open that area, it will be the first node that will pick up the dye. So when it does that, then you get that node, you remove the node, and in those centers, they're able to do what we call frozen section. They will subject that node will be taken for histopathology while you're still in theater. And if the results come back that that node has malignancy, then you proceed to remove all the nodes. If not, then you don't need to continue doing or the systematic nodal dissection. So the essence of doing sentinel node mapping is to reduce the morbidities that are associated with lymph node dissection. So if you're doing sentinel node, you might do a systematic dissection, or from that you get a diagnosis and you stop doing the lymph node dissection. So the last statement about the margin. So when you do your wide excision, you have to make sure you have at least 1 centimeter free margin of tumor. Yeah. If you have anything, so we talk about 8 millimeter or 1 centimeter. Yeah. So if you have anything less than 8 millimeter margin, that means either you need to go back and get more margin if you did the surgery, or you have to put the patient under radiotherapy. So for you to say you have done a good job and you may not need any adjuvant treatment. When you say adjuvant treatment here is either chemo or radiotherapy, is you need at least more than 8 millimeter free margin of the cancer. So the other details is a lot of details, but I think you have done justice to the topic. Thank you very much.
Thank you. If there are any questions, you can raise them at this point. Should we go to the next topic, Daktari?
Any reactions from the rest? Any clarification? Thank you very much, Dr. Nicholas. Are you the same person proceeding with the next topic?
Yes.
Okay, okay.
Good afternoon, this is Dr. Anisa. You're presenting on cervical cancer next?
No, the next one was vaginal cancer, but we can go to cervical cancer first.
Okay.
Okay, so I'll invite
Nicholas. Sorry, Dr.
Yes?
Anisa. Do you think you can finish up on the vagina? Sorry, I have something else.
Oh, you're the one doing it?
Yes, yes.
Oh yeah, sure. I think I joined earlier than I should have.
Okay. Are the slides visible?
Yes, they are. Thank you.
Okay. So the next topic is vaginal cancer. Just to give an introduction into the topic. So the malignant diseases of the vagina can either be primary malignancies or metastatic malignancies. So if they are metastatic, they are either from adjacent structures or distant organs with metastasis to the vagina. And primary vaginal CA usually arise solely from the vagina with no involvement of external cervical OS proximally or the vulva distally. So if there is involvement of the external OS, such malignancies are considered as cervical CA. And if there is involvement of the vulva and the vagina, they are usually considered under the vulva CA. And about 80% of the vaginal CA are usually metastatic with the primary site of malignancy being either the cervix or the endometrium.
Sorry, Nicholas. What is OS? Let's use terminologies that are acceptable. What is OS? External?
Oh, sorry. Maybe you can help me there.
Orifice.
Oh, okay. So external orifice of the cervix. Okay. Thank you. So in terms of epidemiology, the primary vaginal CA is very rare and actually occurs in only 1 to 2% of all the malignancies, gynecological malignancies. And it usually ranks 5th in the frequency of malignancies behind the uterine, cervical, ovarian, and vulvar CA, and occurs mainly in the older women. As we also mentioned, it's the case for the vulvar carcinoma. And the average age at diagnosis is around 67 years. So there are several risk factors as well involved in the onset of vaginal carcinoma. So HPV infection as well is a major risk factor. And in this case, we said that in the vulvar CA, most common subtypes is 16 and 33. In this case, it's 16 and 18. And also we have precursor lesions, which in this case is vaginal intraepithelial neoplasia. And infections can also predispose to vaginal CA. And the most commonly implicated is the herpes simplex virus and Trichomonas vaginalis. So it can also occur in a patient with a history of cervical intraepithelial neoplasia or invasive cervical CA or invasive vulvar carcinoma. Diethyl stilbestro use is associated with the occurrence of vaginal CA and also hysterectomy. In terms of age as a risk factor, it can either be in the young women or in the older women. So in the younger women, it is usually associated with malignancies in the upper part of the vagina, and in the older women, the malignancy is exophytic. Classification is also follows the histological classification, and as is the case for vulvar carcinoma, the most common subtype is the squamous cell carcinoma, accounting for around 85 to 87%. We can also have other subtypes, including the verrucous carcinoma, clear cell adenocarcinoma, melanoma, sarcoma botryoides, endodermal sinus tumor, and leiomyosarcoma. So pathogenesis, there is no a clear-cut way through which the disease develops. So it depends on the predisposing risk factors. So it determines the pathway for development of the malignancies. So if usually a patient will have a vaginal intraepithelial neoplasia, and then that will progress to being carcinoma in situ and possible microinvasive carcinoma, and finally they will develop invasive CA. So it's usually a continuum of transformation from less malignant and to more malignant invasive CA, and this is the process of carcinogenesis with the precursor lesions being risk factors. In the case of HPV infection, most patients develop squamous cell carcinoma, and also vaginal irritation can be involved in the development of the CA. And if such is the case, the malignancies develop mostly in the upper third of the vagina. So the upper posterior wall is the most common site. If there is a presence of irritating substances such as semen and vaginal secretions. And the pathway is because of the pulling of these secretions in the posterior fornix, which cause chronic irritation, and that chronic irritation and inflammation could predispose to the initiation of carcinogenesis, which eventually leads to formation of the vaginal carcinoma. So patients will come with symptoms which have been delayed for around 6 to 12 months. And this is the period for delay before diagnosis for most patients. And some will have vaginal bleeding, which is painless. And this is the most common symptom at presentation and accounts for 65 to 80% of all presentations. In postmenopausal women, there is bleeding in about 70% of such patients. And other types of bleeding can include menorrhagia, that is heavy menstrual flow, or intermenstrual bleeding, or postcoital bleeding. Some women, 30% of them will come with vaginal discharge, and some will come with urinary symptoms such as bladder pain, dysuria, urgency, hematuria, and these are usually related to the anatomical relation of the vagina to the urinary system. So if there is local invasion into the bladder and the urethra, then they might have these symptoms of bladder irritation, and therefore develop the above symptoms. They might also complain of pelvic pain or constipation. And this again is due to the relation of the vagina to the rectus and the rectum and the sigmoid colon. So because of the compression or local spread, it might lead to these symptoms. So diagnosis again follows various approaches. But at the encounter with the patient, you will need to do a cytological screening of the cervix and the vagina, and that of course will follow the biopsy. You do biopsy for cytology, and then you do careful inspection and palpation of the genital tract. And so in this case, staining is usually done with half Lugol's iodine to help mark areas of adenosis. And colposcopy is also useful in this case, and it's only performed if the cytologic findings are positive. So if they are negative, you don't need to do a colposcopy. And a note is that in young girls who have been exposed to diethylstilbestrol in utero, they should get routine examination starting from puberty or the age of 14 years. Yeah, and
Nicholas,
yes.
sorry, can we spend more time on this slide of diagnosis?
Yes.
So for you to make a diagnosis of any cancer, you need a histological diagnosis. So because of the relationship between cervical, vaginal, and vulval cancer, there is need to also do cytological screening. And I think you mentioned that you do Lugol's iodine. So I think we need to visit our screening room. For us here, we do visual inspection with acetic acid. I know in some centers they can also use Lugol's iodine, but for our center we use 3 to 5% acetic acid for that. So once you have to get a biopsy, for a tissue biopsy, because of the proximity between the vagina and the cervix and the vulva, you need to do the acetic acid, the cytology, yeah. And then for lesions that are not very clear, then you can do colposcopy And then you can do the colposcopy and do colposcopic directed biopsy. Okay. So in our setup here, we do with acetic acid, but you can also use Lugol's iodine. If you use both, you increase the sensitivity. Yeah. Same thing about DES. Maybe did you read about what is DES and why are we talking about a lot of DES exposure? Nowadays, we don't get a lot of diethyl stilbestrol exposure. Anything that you know about DES? From your reading, did you come across what is this DES that we're talking about?
So diethyl stilbestrol is used in hormonal therapy, replacement therapy for women. Although I didn't read in depth about the drug. Yeah. So could you please?
Anybody wants to comment before I add on it? So DES is a steroid that was used long time ago for patients who had issues of what we call recurrent pregnancy loss. Yeah. So it seems that there was some, it actually got transferred to these babies born from mothers who had used that for recurrent pregnancy loss. And then, so actually there was a case report done for like a number of patients who developed some vaginal lesions. And when they retrospectively look back, these are patients who were exposed to mothers who had used this DES. And for them, the histological type of the cancer is the clear cell type, not the squamous cell type. Okay, so right now the drug is banned, so you hardly get the clear cell cancer due to DES. You can have clear cell cancer of the vagina, but not mostly due to the DES exposure. Okay. Because of the interest of time, I won't go into more details.
All right, thank you.
Dr. Faizza. Dr. Faizza.
Yes, Dr. Itsura.
Yeah, I just wanted to add on it, on what you have said. Actually, DES was being used to manage hyperemesis in early pregnancy, in the early 60s. This diestral stilbestrol. Actually, it converts into testosterone during the conversion in the cycle or in the metabolism. But as you have said, it has been banned and people no longer use it to manage either recurrent miscarriages or hyperemesis during early organogenesis.
Thank you so much, Dr. Itsura, for that addition.
Okay, so staging for vaginal CA is done using the figure staging system. So again, there are four stages. We have in stage 0, we have carcinoma in situ, so which is also referred to as vaginal intraepithelial neoplasia. And in stage 1, the carcinoma is limited to the vaginal wall. In stage 2, the carcinoma involves the subvaginal tissue, but does not extend to the pelvic wall. In stage 3, it extends to the pelvic wall, and in stage 4, it extends beyond the true pelvis or involves the mucosa of the rectum or bladder. And this is where we talk about the invasion of the bladder and rectum with presentation with those symptoms of bladder irritation or rectum compression. And there is bullous edema, which precludes inclusion in stage 4 classification, and it can be divided into stage 4A and stage 4B. So in 4A, we have the invasion of the bladder or rectal mucosa, or direct extension beyond the true pelvis. And then in stage 4B, there is someone who has their microphone on. Okay, so in stage 4B, the carcinoma spreads to distant organs. So in terms of treatment, there are various approaches as well. And one of them is surgical approach, where you can either do vaginectomy or pelvic extension. You can also do chemotherapy, radiotherapy, which may be given to the lymph nodes near the tumors in the lower part of the vagina, and also do supportive treatment, as we talked about in the vulvar carcinoma. But these are usually done in combination, and they depend on the FIGO stage which the patient presents with. So that is the importance of doing staging before management. So for stage 1 and 2 malignancies, the approach is surgical removal of the tumor, including part of or all of the vagina, and possible removal of the pelvic lymph nodes. And in some patients, this can be followed by radiotherapy with or without low-dose chemotherapy. You can also do internal radiation therapy in these patients with or without external beam radiation therapy. For stages 3 and 4A, you can do combined internal radiation therapy and external beam radiation therapy. And it is oftenly done with concurrent low-dose chemotherapy. And also you can do systemic chemotherapy for selected patients according to indication. And for stage 4B, you do radiation therapy and systemic chemotherapy. So that is the treatment approach.
Nicholas, can I stop you a bit on
Yes.
that area? So management will depend on a number of things. One is the site of the lesion, the size of the lesion, and the stage, yes? So the mainstay of treatment for vaginal cancer is actually radiotherapy. So surgery has a role, but very limited role, because it depends on where the lesion is. So like you rightly put it, if it's a lesion that is on stage 1, that is near the cervix, then you can actually do either vaginectomy, or you can now remove plus the uterus and that lesion and the lymph nodes. So, but the mainstay of treatment for vaginal cancer is actually radiotherapy. So what you're trying to call internal radiation here is what we call by radiotherapy terminologies is brachytherapy, okay? So radiation can either be brachytherapy or external beam, okay? So what you are calling internal radiation is, by better term, is brachytherapy, okay? So brachytherapy has a role plus or minus external beam radiation, okay? And then systemic chemotherapy, like you've rightly put it. Is it clear?
Yes, that's clear. And yeah, that marks the end of my presentation. So Doctor, you can also go ahead and comment on the entire topic, and also we get questions.
So thank you very much, Nicholas, for the wonderful summary that you've done. You've done very justice to both topics. Vulval vaginal cancer, they're very rare, but very important, very unique, and they have some similarities. So just to summarize, is these two cancers are very rare, but they're both HPV related. And also there's also an element of HIV. So when you have HPV, most of the time you should also be thinking about HIV. Mostly affect the older women, but for vulva, we know it has a bimodal age distribution. So it has the young population and the older population. But vaginal cancer, most of the time, it affects the older women. And both of them, both vulval and vagina, it's the commonest histological type, like you rightly put, is the squamous cell carcinoma. And then you can have the other type. Yeah. So most of the time, you should remember that the older women, very few will actually come out. So pruritus is very common, a discharge, unless they're very conscious. That the time they come is they present most of the time very late. Yeah. So because of the late presentation, surgery has a very limited role, and mostly we do radiotherapy, maybe chemo and radiotherapy. But you need to make a good diagnosis. And how do you make a diagnosis? You need a tissue biopsy. And the way we do our tissue biopsy, if you visit the screening room 23, we have a special tool that we use, but it doesn't mean that you need to have the keys for you to do that. You can even inject local and get a small piece and subject it for histology. So you need a biopsy, you need to do good examination. You've talked about part of your staging, you need to examine the inguinal nodes. So you need to do good examination, good history taking, and a diagnosis. From there, then you do your investigations based on your diagnosis, and then you manage. But in a nutshell, this has been a very good discussion. Thank you very much.
Thank you, Dr. So I will hand over to Ian Amwatta to take us to cervical and ovarian cancer, and finally endometrium.
Thank you, and I hand over to Dr. Anisa.
Oh, excuse me, Doc.
Yes.
There are some 2 questions in our chat box there, so maybe if we look at them before moving to the next.
Yeah, correct. Sorry, okay, so what does pelvic exenteration entails? What is the prognosis of vaginal and vulval cancer? So Dr. Itsura has tried to answer one, but so when you say exenteration, it involves removal of the pelvic organs. So you can either have an anterior exenteration. So when you remove the pelvic organs plus the bladder, that's the anterior. And then you can have a posterior exenteration, then you move plus the rectum, or you can even have a total exenteration. Yeah, so you're removing a lot of organs. The problem with exenteration is the mobility that is involved, yeah, and then also the psychological aspect, because now you might have to have the urine diverted, the stool diverted as well. So the quality of life of the patient matters. So before you do this kind of extensive surgery, you really have to sit down and counsel the patient that in the long run, you might need to have urine diverted, your stool diverted. But it's when you're now removing you're doing extensive surgery. So the prognosis of any cancer depends on many things. One is if there are comorbidities, the stage of the disease. So if you present early, you have a good prognosis, yeah? But like we said, most of the patients with both vaginal and vulval present late, yeah? So if you're early stage, you have a prognosis of about 80%. But if you present at an advanced stage, like stage 4, your prognosis that definitely will go down to 30%. So it depends on the stage and the echo status, the performance status of the patient.
It's okay, thank you.
Any more questions? Sorry, I was muted. So in case you have any more questions or clarification, I will share my phone number and my email. We can communicate. For the interest of time, I think I will allow the next moderator to take over, Dr. Anisa, and maybe the next presenter.
Okay, thank you, Dr. Faizza and Nicholas for the first 2 presentations. So we'll move on to cervical cancer. May the host allow me to share my screen?
Yeah, you can share now.
Okay, please confirm that you can see the slides and you can hear me.
Yeah, we can.
Okay, thank you. So my name is Amwatta Ian. I'm at 6. I'll be taking you through cervical cancer. We can start. So on epidemiology, so cervical cancer is the most common gynecological cancer worldwide. Second most common, affecting women after breast cancer, with about 500,000 new cases each year and about 247,000 deaths. that is data from 2018. In Kenya, we have about 5250 incidences and about 3286 cancer deaths every year. So that is for that particular year. So higher burden in the low and middle income countries and constitute about 85% of global burden. And this is usually due to presentation, advanced stage presentation. So the median age of diagnosis is about 49 years of age. So late 40s, early 50s, some sources say 50 up to 51 years as the median age. And it's attributed to human papillomavirus serotypes 16 being attributing to 57% and 18 to 16% of invasive cancer. Serotype 16 is associated with the squamous cell and serotype 18 with adenocarcinoma. So on to the risk factors. So we have HPV-related risk factors, and these include early onset of sexual activity. And if you compare to persons who are above 25 years of age, you have a 1.5 fold increase risk when the person is between 18 to 20, and about twofold when they're younger than 18. So the younger the person, there is this increased risk of having HPV, and this subsequently leading to cervical cancer. And then multiple sexual partners, so twofold increase in persons with 2 or more partners, and threefold.
Dr.
Yes.
May I ask you a question? Why is this early age of sexual debut very important? What is the reason behind it?
So there could be multiple reasons, but what I'm thinking of is that with this, as part of plan or prevention of HPV and cervical cancer in general, early onset of sexual activity is something that should be looked at in terms of either if the population can stick to abstinence, or you can have preventive measures in terms of using ovarian methods so that you don't have exposure to HPV, or the HPV vaccine in terms of giving the HPV vaccine before this early exposure to HPV subtypes of viruses.
Okay, what I'm trying to bring about is that whenever you're talking about these risk factors, you need to understand how they come about as risk factors in causing the person to be predisposed to a particular illness or cancer in this case. So for young adolescents or young ladies, they tend to have number one, biological immaturity in terms of the endocervix is still exposed. It has not gone inside as it should be. So the endocervix is thoroughly exposed to the vagina, meaning they are at a higher risk of getting in contact with the virus and any other sexually transmitted infections. So it's easier for them to get the infections. And number two, their immune system is also not mature enough to be able to successfully fight out these infections. So with these two main reasons, biological in terms of anatomy and immunological issues, it predisposes them even more to being unable to clear the virus and forgetting the virus even faster compared to an adult. Okay, so whenever you're thinking of something, at least try to understand how it brings about a change.
Thank you for that. So on to the next risk factor. So having multiple sexual partners with a twofold increase in persons with 2 partners and a threefold increase in more than 6 partners. And this is attributed to exposure to various subtypes of HPV, the human papillomavirus. And so the more sexual partners you have, the more the risk of being exposed to different serotypes of HPV. So a high sexual partner in terms of having a partner who has multiple partners, or a partner who has been known to have HPV, or a partner who also doesn't practice barrier methods of prevention of spread of the HPV. So having a high sexual partner, a history of STIs, early age at first birth. So people who have the first child before 20 years of age, and also increasing parity, that is 3 or more full-term births, are likely to be exposed to more serotypes of HPV. Also, history of valvular and vaginal squamous intraepithelial neoplasia, and not necessarily HPV related, but immunosuppression in terms of HIV infection and other factors that can cause immunosuppression. So on to non-HPV related risk factors. So low socioeconomic status, and this is attributed to, or this results into limited access to healthcare facilities. And by this, I mean limited access to screening services, vaccination services, and which increase the risk of the sequelae of developing cervical cancer. Non-white race, so there is a higher risk in Hispanic Black women who have higher incidences compared to other racial groups. Oral contraceptive use, which increases risk, and this is based on increased duration of use of the oral contraceptives. Cigarette smoking, which is associated with an increased risk of squamous cell carcinoma. And genetics, though not well established, we have an increased incidence of cervical cancer within families. And then cervical cancer is less common in women with sexual partners and circumcised. So on to the etiology. Human papillomavirus infection must be present for cervical cancer to occur, but in its own, just having HPV without any of the other risk factors does not necessarily result into cervical cancer. So 90% of HPV infections are usually clear on their own, and this is usually within a period of 2 years. And in some cases, you have post the 2 years, you have a patient developing low-grade squamous intraepithelial lesion. So about 5% of the HPV infections will result in carcinoma in situ, grade 2 or grade 3, within 3 years of infection. And out of this, only 20% of the carcinoma in situ progress to invasive cervical cancer within 5 years, and 40% of the carcinoma in situ 3 progressing to invasive cervical cancer within 30 years. So on to the different serotypes of HPV. So you have 16 being the most carcinogenic HPV type, and is known to cause cancer at several sites, not just the cervix. And then you have the 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, and 59, which evidence, there is sufficient evidence to show that they are associated with cervical cancer. So you also have other serotypes like the 68, the 26, 53, the 30, 34, which don't really have, there is limited evidence in terms of them causing cervical cancer in humans. And then the 6 and 11, which are more associated with benign lesions rather than the cervical cancer itself. So HPV is a double-stranded DNA virus. It usually has these frame proteins, the E1, E2, E3, E4, E6, and E7, which are usually regulatory proteins. And of interest is the E6 and E7. So there are more than 115 different genotypes of HPV that have been identified. So between 115 to about 130. And there is, out of all these different genotypes, we have 90% of cervical cancers are caused by eight subtypes. And these are the 16, the 18, the 31, the 33, 35, 45, 52, and 58. So upon integration into the human genome, there is usually binding and inactivation of the RB gene and also the TP53. And this is E7 binding to the RB gene, and then E6 binding to the P53 gene, which results in this sort of uncensored cell growth after DNA damage. And this is what usually results into progression to malignancy. So HIV is also known to, of course, suppress already low level of immune recognition of HPV, allowing the HPV virus to cause more damage. So just from the natural history of this disease, without intervention, so you can have the HPV infection resulting into either symptomatic latent infection, active infection, but without integration into the genome, and neoplastic transformation, which follows integration into the oncogenic HPV DNA into the human genome. So with just an infection of the HPV virus, the human papilloma virus, you can result into the 3. And once you have the integration of the E6 and E7, resulting into dysregulation of the P53 and the RB genes, then you have the neoplastic process going on. So this usually takes place mostly at the transformation zone, and we'll talk about the transformation zone in subsequent slides. So at least 90% of squamous cell carcinomas of the cervix develop in intraepithelial layers, and this is usually about 1 centimeter from the squamous junction of the cervix, either on the portovaginalis of the cervix or at a higher or a slightly higher in the endocervical canal. So with this sort of like stromal invasion, so you'll have the different stages of the disease, and I'm talking about the natural history without intervention. So you can have stromal invasion resulting into the stage A1, and with this you usually don't have a lymphovascular sort of spread. And so at that particular point, you're able to manage this patient using methods such as colonization, which you're going to talk about. But once you have penetration of the stroma beyond that point, beyond the 3 millimeters in terms of depth, then you have an increased risk of lymphovascular spread. So with the lymphovascular spread, with the lymphatic spread, you usually have spread to the regional nodes, and these are the parametrial, the hypogastric, the obturator, external iliac, and the sacral nodes.
You're not seeing the results.
Sorry. So you can have the lymphatic spread to the parametrial, the hypogastric, the obturator, external, sacral, and once you have the spread of the cancer to a level of parametrium, then you have about the pelvic nodes being involved in about 30 to 40%, and paraortic nodes being involved in 15 to 30% of cases. So the more advanced the local disease, then the greater the likelihood of distance metastasis. So in patients who have stage 4A disease, they usually have about 45% involvement of the paraortic nodes. So you can also have a spread to the ovary, but not that common. So in terms of the hematogenous spread, you can have metastasis or spread to the liver and the lungs mainly, but you can also have the tumor involving the brain, the bones, the bowels, adrenal glands, spleen, and also the pancreas. So without any intervention from start to end, these patients usually have 95% of patients usually die within 2 years after the onset of symptoms, and the cause of death the pelvic wall with hydronephrosis, or pulmonary embolism, this is of the tumor itself, or hemorrhage from direct extension of the tumor into the blood vessels. You can also have a life-threatening sepsis and also large bowel obstruction into the retrosigmoid, being part of the terminal fence. So you can also have pain from perineural extension with significant management of the advanced. And so all this just show you how this disease can be very aggressive, and it's very important to address and diagnose and have early intervention before you end up with the advanced, which is also a problem because most patients come to the advanced stage. So in terms of the histopathological subtypes, so
just a minute, Dr.
Yes.
These 3 slides that you've shared are very, very important. When you're looking at the patterns of spread, they will also tell you the patterns of failure. So in terms of once you understand how the disease spreads, so you know that once it's in the cervix, the first thing it's going to do is move locally, then it gets into the lymph nodes, and then it can get into the hematological system. Now, the point of this is that you're able to determine the kind of treatment or the additional treatment that the patient will need, because you can be able to predict the next part that's going to be affected and whether you need to give what we are talking about, adjuvant therapies or not. So that this is very, very important to understand, and this is where your anatomy comes in, and it also explains the kind of surgeries that we do, which I'm sure we'll talk about later, but you need to understand this anatomy. Okay, and then Dr. Your sound is not very clear. There's a lot of interruption in the background. Could you maybe move closer to your microphone?
Okay, can you hear me better now?
Rather.
The background might be very tricky to control, but I'll try to be as audible as much as I can. So we can move on to the cell carcinoma. And then you can also have the adenocarcinoma, which can be mucinous and the cervical variant, mucinous intestinal type. You can also have the adenosquamous carcinoma, the adenoid cystic carcinoma, the neuroendocrine undifferentiated carcinoma, and mixed epithelial and mesenchymal tumors. So about 80% of cervical cancers are squamous cell, and about 20% being adenocarcinomas, and 3 to 5% being adenosquamous carcinomas. So the large cell, the non-keratinizing variant accounts for the majority of the squamous cell. The vicarious carcinoma, which is usually slow growing and locally invasive, is more attributed to human papilloma virus 6. So in terms of clinical presentation, we'll go into, so some of the early symptoms that these patients usually come with include vaginal discharge, irregular vaginal bleeding, postcoital bleeding, postmenopausal bleeding, and the late usually attributed to spread of the disease include urinary frequency and urgency, backache, lower abdominal pain, severe back pain, weight loss, and oliguria. So the most common symptoms are usually abnormal vaginal bleeding, which can be bloodstained, pleural discharge, scant spotting, or frank bleeding, and then vaginal discharge, which can be watery, mucoid, purulent, malodorous, history of coital bleeding, pelvic pain, radiating to the thigh, usually more of advanced disease. They can also come with constitutional symptoms, including weight loss, or as a result of the abdominal vaginal bleeding, they can still come with anemia and signs of anemia.
Sorry, is it just me or I cannot hear Dr. anymore? Did we lose our presenter?
It seems there is a problem with the internet here. So just a short while, he'll be back. Yeah, he's back.
Sorry, there was a problem with my connection. You can hear me.
Oh, it's okay. Continue.
Okay, so on a general examination, I find a patient who is cachexia. Of course, if they've been losing a lot of blood, they might have pallor, showing anemia, and of course, you'll do the same way we usually do our physical exam, but more into the pelvic examination. So pelvic examination, of course, you'll start with a examination of the external genitalia, and then you'll move on to do your okay, so of course you start with examination of the external genitalia, and then you move on to your speculum examination. So most patients or most women with invasive cervical cancer. So when you're doing your speculum examination, so you can either, when you're looking at the cervix, you can have an exophytic mass, which is usually the most common sort of like a finding that you'll have in more than 50% of these patients, or you can have just an ulceration, a superficial ulceration, or you can have an sort of like an endophytic tumor, and this will be more of like in terms of the appearance of the cervix itself.
Okay. You need to advance your slides as well so that they can match what you're discussing. But one thing you need to be aware of when you're doing your vaginal exam, you will do your speculum and you also do a digital exam. So once you insert your fingers into the vagina, you want to feel for the width and the length of the cervix or of the tumor, which might be including the entire cervix. So once you feel that, you also want to check whether the spaces between the vaginal fornices and the cervix, if they're affected, because that is going to indicate whether the parametrium are involved or not. You also you can also check the pelvic wall by turning your fingers laterally on both sides, right and left, so that if you feel any nodular swellings on the pelvic wall, this is the ilium of the pelvic bone, you will know that the pelvic bone is also affected. After you do that, you have to do a DRE so that you check the rectal mucosa to make sure it's free. You'll want to check if it's stiff and also very nodular, or just the mass is pressing upon it, then you also need to state. From the rectal exam, you'll also be able to determine whether the parametrium are involved or not.
Thank you for that.
So Ian, can you advance your slides?
Yes. So we've talked about the pelvic examination and talked about having an endophytic, an ulceration, or an endophytic tumor. So we'll move on to staging of cervical cancer. So you have stage 1 to 4. So stage 1 is usually diagnosed by microscopy, and you have stage 1A1, where you have stromal invasion less than 3 millimeters in depth. And then
so sorry, Dr. the slide that we are seeing is the first slide on cervical cancer. Do you want to share the slide where you're at?
Let me just try and do that again. I thought you were together.
You can try stopping sharing and then you share again.
Yeah.
It'll be okay.
So as he's going into the staging, I just have to ask, we were only dealing with cervical cancer. We're not dealing with the pre-invasive and cervical cancer screening. Hello?
Oh, are we together? Are we in the staging slide? Please just confirm.
Yes.
Okay.
Yeah.
Oh, yeah, we'll still talk about screening for cervical cancer. So stage 1A1, you have a stromal invasion of less than 3 millimeters in depth, and stage 1A2 having a stromal invasion of between 3 and 5 millimeters in depth. And then stage 1B, usually depth of invasion is more than 5 millimeters. The lesion is limited to this cervix. So you have stage 1B1, where the depth is more than 5 millimeters, but it's less than 2 centimeters in terms of the greatest dimension. And then stage 1B2, which is between 2 and 4 centimeters in the greatest dimension. And then 1B3, which is more than 4 centimeters in the greatest dimension. And then for stage 2, this is a tumor which has extended beyond the uterus, but not to the lower third of the vagina or to the pelvic wall. And so you have stage 2A, 2A1, being tumor limited to the upper thirds of the vagina without parametrial involvement, but less than 4 centimeters in the greatest dimension. And then 2A2, which is again limited to the upper 2/3 of the vagina, but without parametrial involvement, but more than 4 centimeters in the greatest dimension. And then stage 2B, which is parametrial involvement, but not up to the pelvic wall. And then for stage 3, now you have a tumor involving the lower third of the vagina and extending to the pelvic wall, causing hydronephrosis or non-functioning kidney, and or involves the pelvic and the paraortic nodes. So stage 3A usually involves the lower third of the vagina with no extension to the pelvic wall. 3B, extension to the pelvic wall with or without hydronephrosis or non-functional kidneys, where you don't have any other cause. And then stage 3C, where you have involvement of the pelvic paraortic nodes, irrespective of the tumor size. And you can have 3C1, where you have pelvic lymph node metastasis only, and 3C2, where you have paraortic node metastasis. For stage 4, you have tumor extending beyond the true pelvis and has involved the mucosa of the bladder and the rectum. And so that explains the importance of doing a rectal exam. So stage 4A, you'll have spread to adjacent organs, and then B, spread to distant organs. So in terms of the other investigations that you can have, so you can do a Papa Nicolau smear, which usually is a cervical smear, and it involves collecting specimen using a spatula or a brush by scraping the endocervix and the ectocervix, and then applying it to a glass slide, fixation using alcohol, and then staying with the Papa Nicolau dye. After that, you do interpretation of the cytological smear using the Bethesda system. And the Bethesda system usually has either you'll see atypical squamous cells, or low-grade squamous intraepithelial lesion, or high-grade squamous intraepithelial lesion, or you'll have the basal membrane intact, which usually shows carcinoma in situ. You can do colposcopy, which is basically use sort of like a microscopy to visualize lesions. And with that, you can also do directed biopsies of any lesions that you're seeing. May indicate hyperkeratosis, parakeratosis, cervical intraepithelial neoplasia, and usually arising at or near the transformation zone. And with the colposcopy, you can do further directed biopsy. So you can do cervical cytology. So the principal method for cervical screening when cervical cancer is suspected. So you usually have HPV testing, which is actually the principal method of cervical cancer screening, but this is usually for majorly for patients above 30 years of age. So you can do cervical biopsy. Remember, when you're doing your speculum exam and you have an exophytic mass, then you can just go ahead and do a biopsy. It's usually done in part of the initial evaluation, and depending on the level of suspicion and also the patient's access to healthcare. So if it's a grossly visible lesion, as I've said, then you can just do the biopsy. So if you don't have, or if the patient, if there is no visible lesion, if you're having like an endophytic sort of like mass, then you can go ahead and do the colposcopy, and then you do the directed biopsy. So in terms of the biopsy technique, if the cervix is, if you have biopsy from the area of the lesion that looks suspicious, and you try to avoid the necrotic areas, as those are not usually diagnostic. And then if you have an unusually firm or expanded cervix, then you can do a punch biopsy or endocervical curettage, even if the cytological tests do not show evidence of neoplasia. So fauconization, which can be both a diagnostic and also a therapeutic procedure. So it usually involves excision of a cone of the cervical tissue that contains both part of the ectocervix and also the endocervix. Can be performed using cold knife or loop electrosurgical or Anisa, and usually include the transformation zone as it's the most common site of carcinoma in situ. So there is usually kind of like a change in the position. There is a positional change of the transformation zone depending on the age of the patient. In the premenopausal period, usually have the transformation zone located more on the ectocervix, and so you do a shallow cone. Patients who are postmenopausal usually have the transformation zone located more on the endocervix, and so you do a deep cone. So indications, if malignancy is suspected but is not found on directed cervical biopsies, and in the setting of microinvasive cancer, to determine whether conservative or radical surgery is required for treatment. Complications that can arise from conization include cervical stenosis, postoperative bleed, cervical insufficiency during pregnancy, and also infection and uterine perforation. Part of the investigations that you can do, you can have imaging. So depending on what you're looking for, you can have an abdominopelvic CT scan, which can show you the tumor size, can show you if there is extension to the parametria, it can show you extensions of the vagina. Basically, what you're having is a metastatic scan, and can also show you like metastasis to distal organs. So you can have the different types of the imaging modalities. So we'll move carcinoma.
All right, let me interrupt you a little bit.
Okay.
I just need you to have it clear in terms of screening of cervical cancer. So we understand that for pre-invasive lesions, they rarely might have any symptoms. Occasionally, a patient can have the postcoital bleeding or a bit of discharge. But the point of screening is to discover disease before the cancer has actually developed. So when you're coming to screening modalities, it's mostly age-based. So for those who are 21 years and below, we do not routinely screen them because we expect them, they might have as soon as they have sexual contact, at least 80% of women will be infected with HPV, but most women are able to clear it. However, from our different guidelines, we'll say from 25 years or either 30 years, then you start testing with the HPV DNA. And with the HPV DNA, it gives you a full spectrum, including the non-cancer causing and the high-risk types as well, all the way up to 58. That is the one that has been instituted as the main screening methods in most countries. However, in our setting, because of lack of enough resources, we do visual inspection with acetic acid. And you need to understand the principles behind the VIA. For those of you who have attended cervical cancer screening, you have seen what we do. We use the usual vinegar to be able to stain and get an acetoate reaction and thereby guide our biopsies. For some centers, they will use the iodine, and you need to understand for the VIA and the Lugol's iodine, why the changes occur when they occur. We're talking about the glycogen changes with the iodine, and you're talking about the protein coagulation with the acetic acid. So you need to be able to differentiate, because when you're doing some of this tests, the VIA and the villi, some conditions like chronic cervicitis or a cervical polyp, they can give you false positives. So you should be able to differentiate which is an actual pre-malignant lesion and which is not. So you should be able to at least look at different images and be able to pick up and do biopsies appropriately. Then also in terms of screening, we have the pap smears. When you're doing pap smears, as he said, you can use a brush or a spatula, and you can also have a liquid-based monolayer. Both have a similar mechanism behind them, but for the liquid-based monolayer, it's more efficient compared to the pap smear. But out of this, you have the Bethesda classification of the dysplastic conditions, and for each, you have to understand which ones are there. Like for if you have a high-grade lesion, if you have a low-grade lesion, you have atypical squamous cells or atypical glandular cells, you have to understand what it means and how you institute the management. So sometimes we use both methods, like we say we are core testing or we're doing reflex testing. For example, if a patient does a pap smear and she's above 25 years, then the pap smear is positive, then you can do reflex testing with the HPV DNA. For others, you can do HPV DNA and then you do together with the pap smear together at the same time. That's for testing. So these are some of the things you have to understand when it comes to screening. And then when you're coming to the modalities of management, I find it easier to understand them or know them when you divide them into excision methods and ablative methods. So the ablative methods are such as cryotherapy, and you need to understand when it is indicated and some of the complications that arise from it. For excision therapies, we have, like you mentioned, the cone biopsy, you have the lip. I think some of you have seen how we do it. And you have to understand what you need to tell the woman in terms of how the procedure will be, and after the procedure, some of the things that you need to advise her that she's going to experience. So it's important for you to understand these elements when you're talking about screening. Please proceed.
Thank you for those additions. Basically, Doc has talked about most of the things that we are going to talk about, including the treatment options when you're having carcinoma in situ, the ablative methods, and then the excisional method, which we've already talked about. So we'll basically move on to now the CS cervix, the invasive cancer itself. And so this is the treatment protocol for cervical cancer. So you start with your history, your physical examination, and the cervical biopsy, plus your investigations. And if you're having a patient having stage 1A1, then you can do a cone biopsy. And if they have, if they already have their children, then you can do a simple hysterectomy. For stage 1A2, 1B1, you can do radical hysterectomy plus node dissection. When you're having stage 1B2 to 2A1, then you can do radical hysterectomy plus node dissection, sorry, or primary chemoradiation. And then for stage 1, B3 and 1A2, you can 2A2, then you can do the chemoradiation on your adjuvant chemo. And then for stage 3 to stage 4A chemoradiotherapy, we're going to talk about them individually. So in stage 1A1, we talked about it. You can do the conization, or you can do the hysterectomy for those patients. For stage 1A2, you can do modified radical hysterectomy and lymph and pelvic lymphadenectomy, or you can do radical trachelectomy and lymphadenectomy for fertility preservation. For 1B,
Dr. Allow me to interrupt you. Your slides are frozen on the staging slide. So we're not moving with you.
Sorry about that.
Perhaps going forward, all the presenters can share the slides with one person who has a reliable internet, and then that person can be sharing, just so that to avoid these delays.
Can you see the slide, stage 1B, or it's still frozen?
It's still frozen on the staging.
Okay, sorry about that. So for stage 1A2, you can do modified radical hysterectomy and pelvic lymphadenectomy. But if you want to do, if you want to preserve fertility, then you can do radical trachelectomy and lymphadenectomy. Then for stage 1B to 2A, this can either be managed using surgery or radiation therapy. And you can do radical hysterectomy and pelvic lymphadenectomy or receive primary radiation for these patients. Now for the advanced stage disease, you have locally advanced disease, and this is usually from stage 2B all the way to stage 4A, and then the distant metastatic disease, which is stage 4B. This is an image from yesterday. Was it yesterday? The other day, we were having a brachytherapy on a 57-year-old para7+0 patient our facility. So for the locally advanced disease, so if untreated, these tumors usually progress rapidly. And so the standard treatment is usually concurrent chemoradiation, and this is platinum-based chemoradiation. And it's the chemo part is for radiation sensitization. So the platinum analogs act as the radiation sensitizers. So the chemotherapy usually involves intravenous administration of weekly cisplatin during the course of external beam radiation therapy, and one weekly infusion of cisplatin. This is for about 5 to 6 cycles during the external beam radiation therapy. For patients who are unable to receive the platinum chemotherapy for one reason or other, then you can do fluorouracil, 5-fluorouracil-based regimens. So for the radiation protocol usually involves a combination of external beam radiation therapy plus the CCRT, which maximizes the likelihood of locoregional control while minimizing the risk of treatment complications. And the goal for the external beam radiation is to sterilize local disease and also to shrink the tumor. And that is basically kind of like the dosages from 45 to 50 grades. So you can also have intracavitary radiation therapy, which is basically the brachytherapy that we do in our setup. Although this is not feasible for patients who have distorted anatomy or you have inadequate dosimetry. And this usually can involves the use of multiple needles or catheters into the primary tumor and the parametrium through the perineum with the help of a template. So the completion of the radiotherapy protocol is it's essential to finish
sure
it,
is a matter of
with kindly mute. Okay, thank you. So completion of the radiotherapy protocol within stipulated time is usually very important, as this is related with the there is a direct correlation with the outcome, and so it's recommended that the entire protocol of the external beam radiation therapy and the brachytherapy is done within 8 weeks. So this is just a sample of the 8-week protocol, which involves 5 weeks of the cisplatin once weekly, and then 25 sessions of the external beam radiation 5 times a week for 5 weeks, and 2 sessions of brachytherapy. So between week 1 and week 5, you do the cisplatin, the external beam radiation, and then you rest for the weekend. And then week 7, week 8, you do once weekly brachytherapy. For the distant metastatic disease, that is stage 4B, so this usually has a poor prognosis with a median survival of about 7 months. And we manage these patients mostly as palliative patients. So the palliative care involves controlling symptomatology and basically improving the quality of life of the patients. So if they're having persistent nausea and vomiting, you can have them on ondansetron, or you can have them on a gastrostomy tube. If they're having bowel obstruction, you can manage them surgically. Percutaneous nephrostomy for those patients who are having hydronephrosis as a result of urinary tract obstruction. pain management for these patients, and also, of course, pain management. So screening, the doc already talked about screening, and we said that from ages of 25 all the way to 65, you do every 5 years, except for those who are HIV seroreactive, then you do it every year, 1 to 2 years. So this is the Kenyan program. Again, Doc already talked about it. He talked about the VIA and the VLI and post-treatment screening. So we'll move on to prevention. And this one I'm looking at the HPV vaccine. So we have 3 vaccines which are currently available. So the bivalent Cervical, which covers the HPV 16 and 18. And then you have the Gardasil 4, which is a quadrivalent vaccine, covers 16, 18, 6, and 11. And then you have the Gardasil 9, which is a monovalent vaccine, covers 6, 11, 16, 18, 31, 33, 45, 52, and 58. So vaccination is advocated for patients who are between 9 to 26 years of age, but mostly targeting between 9 and 11 years of age before the exposure to several genotypes of the HPV. But you can still go on all the way to 26 years. So above the age of 26, it depends on, so it's not advisable, but you can still have the vaccination, although the efficacy at that particular point is not very high. So it's given us 3 doses over a period of 6 months. So you can do it at 0, 1 to 2, at 0 months, then after 1 to 2 months, and then at 6 months. And for those between 9 and 13 years of age, the CDC recommends 2 doses instead of 3 doses. So just a bit of cervical cancer in pregnancy. So there is an incidence of about, it's not common, but 1 to 10 in 1,000 pregnant women. That's according to a study done in Portugal. So most usually come in stage 1 with abnormal bleeding being the most common presentation. 20% are usually asymptomatic. So what makes it a dilemma is that who do you save exactly? Do you save the baby? Do you save the mother? And the malignant disease itself complicates both the management of the cancer and the pregnancy. So factors to take into consideration include the period of gestation, the survival of the fetus, and the features of the patient. So you can do cervical biopsies, can be done, but you tend to avoid endocervical curettage. But even with cone biopsy, there is risk of hemorrhage, infection, pregnancy loss, and preterm labor. In terms of management, so it's multidisciplinary. Usually follow the same principles as pregnant states, and within if the mother is between or before 16 to 20 weeks, then you have to treat them without delay. And the mode of therapy can either be surgical or chemoradiation, depending on the stage of disease. And for late trimester, then you can use surgery. Chemotherapy can be used in selected cases while trying to preserve the pregnancy. So when the diagnosis is made after 20 weeks, then delaying definitive treatment is valid options for stage A12, 1B1, and 1B2, which has not been shown to have any negative impact on the prognosis compared to non-pregnant protocols. And then for patients with microvascular carcinoma, then you can follow them up all the way to term, and then you reevaluate them after delivery. For advanced disease, then treatment modality is the same as the non-pregnant, with delivery of the fetus by classical cesarean section. So effects of radiotherapy in these patients, given that they are expectant. So between 2 to 6 weeks, you can have malformation and growth retardation. Within 12 and 16 weeks, mental and growth retardation or microcephaly. Between 20 to 25 weeks, all the way to birth, you can have sterility, malignancies, and genetic disorders. And the risk of chemotherapy in the pregnant patients includes spontaneous abortions, malformations, teratogenesis, mutations, carcinogenesis, organ toxicity, and retarded development. Those were my references. That is the end of the presentation.
Thank you, Dr. Sorry, I stole your thunder. You know, in my mind, the screening was to come even before we talked about cervical cancer. So that's why I thought we weren't going to talk about it. But either way, that was a good presentation. There are just a few things that you have to be aware of in terms of treatment of cervical cancer. There's some high risk or some risk factors that we look at in order to determine the kind of therapy that we offer them. And some of you have probably heard us in the clinic talking about Sedley's criteria or Peters criteria. These ones are some elements that have been established that will tell us whether this patient is at a high risk of disease progression and thus requires adjuvant therapies. And for most of the things that we look at is the depth of stromal invasion, which you mentioned very well, the size of the tumor. In a large tumor, meaning it's 4 centimeters and above, it means there's need for adjuvant treatment. In most cases, it's radiotherapy, and lymphovascular space invasion. So most of this, especially the first two, they'll be told mostly by the histology, and probably and likely after a radical hysterectomy or even on examination. When it comes to the Peters criteria, these patients mostly have undergone a radical hysterectomy, where now the histological specimen comes back with either positive margin, positive nodes, or positive parametria. So again, if the patient has any of these risk factors, at least two or more of these risk factors, it means that they need adjuvant therapy. As you correctly said, the main therapy that we use is chemotherapy with radiation therapy. Occasionally, radiotherapy will be given on its own, especially if the patient only has a few of the Sedley's criteria. But the most important thing that you have to be aware of is when you have such bulky tumors like the 1B3 and above, it is better for the patient to start them off with the radiotherapy. Now, the reason for this is because of the side effects that come out of radiotherapy. Now, these are things that you probably need to read about, the acute and late side effects of radiotherapy. So when you have a uterus there, and you're giving the patient radio, it really helps to reduce the amount of radiation that gets to the bladder and to the rectum, especially the rectum. And so helps to reduce the amount of side effects that these patients have. For pregnant women, there have been occasions where we've, perhaps if they're in the second trimester and we're seeing that this is maybe a bulky tumor, meaning it's about 4 centimeters or 5 centimeters, and it's just localized to the cervix from imaging, there are options of giving them chemotherapy. And in this sense, we're talking about especially the platinum analogs. It can help shrink the tumor so that by the time they deliver, at least the tumor has shrunk a little bit. You can either do surgery or go ahead with definitive management in terms of maybe chemoradiotherapy. So you correctly mentioned that for the pregnant women, we do a classical incision. Do you know the reason why we do this and not the usual transverse?
Not really.
It's because of bleeding. When you are going, a transverse section usually focuses on the lower uterine segment, and that's where the most of the tumor is, and with tumor comes a lot of vascularity. So you want to avoid that, and you have to go up and make a classical incision, mostly to prevent hemorrhage on the table. I think that's pretty much what I had, but I had also made a presentation for this class. I did not know there was a student presenting. So for the presenter, if you want, you can just put down your email on the chat, and then you can share the presentation once I send it to you, if you're interested.
Awesome.
All right.
Awesome.
All right, so great presentation. Keep studying and keep staying safe.
You too, Doc. Okay, so we can move on to ovarian cancer, if that's okay with the team.
Yes, hi everyone. I'm supposed to coordinate endometrial cancer. I don't know if I thought it was scheduled for 4 p.m. I don't know if your classes were late or they have maybe taken long. Maybe the coordinator can tell me.
It's okay. We can still do endometrial cancer first, then move on to ovarian cancer afterwards.
Okay.
There is a request that we take some break before starting the endometrial cancer.
How many minutes? 5 minutes, yeah?
Yeah, 5 minutes.
Okay.
Hello, is it okay if we continue now?
Yes, 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 please.
All right, thank you. My name is Nicholas Kioko. Med 4. I will be presenting this class on endometrial carcinoma alongside Ian Amwatta, Med 6. So this is an overview of what we're going to cover in this presentation. So we will be mentioning the uterine corpus carcinoma alongside the endometrial cancer, because endometrial cancer and cervical cancer, both of them are part of the uterine cancer. So as depicted here, uterine cancer is defined as any invasive neoplasm of the uterine corpus, and can occur, as I've mentioned, as either an endometrial cancer, if it originates from the cells of the endometrial glands, or as cervical cancer if it arises from the transformation zone of the cervix. And we have already covered the cervical cancer. So now to focus on the endometrial cancer, it's a malignant proliferation of the endometrial glands, and occurs in two distinct pathways, including the hyperplasia pathway and the sporadic pathway. So in the hyperplasia pathway, this mostly involves the action of estrogen, which usually in normal cases occurs in the first phase of the menstruation. So if it occurs, if it's released in large amounts, then it fosters the proliferation of the endometrium, causing unregulated growth, and that can lead to malignant transformation. In the sporadic form, there is no role of estrogen, but the action is usually through mutation, and mostly occurs with atrophic endometrium. So the mutation here is mostly the P53 mutation. So there are various microscopic appearances of endometrial carcinoma, of which adenocarcinoma or the endometrioid CA forms the majority. So about 80% of all the endometrial carcinomas. We also have other types such as adenocarcinoma with squamous elements, papillary serous carcinoma, mucinous adenocarcinoma, clear cell, secretory squamous cell carcinoma, and mixed carcinoma. So just to mention a few prognostic factors when it comes to endometrial carcinoma. So first, whether the squamous component or the adeno component are involved, they confer prognostic factors, because for the squamous component, it has little or no importance in determination of prognosis, but the adeno component usually highly affects the prognosis. Also, prognosis can be influenced by the histologic type of the endometrial CA. So mostly papillary, serous, and the clear cell cell types usually confer poor prognosis. I mean, poor prognosis of development of the endometrial CA. And secretory carcinomas are the least frequently occurring CS, but are associated with good prognosis. So those are some of the prognostic factors that we have to have in mind when you're talking about endometrial CA. In terms of epidemiology, this type of malignancy is the most common gynecological malignancy in developed countries, but in our setting, it's less likely to be more common compared to cervical cancer, which is which has a higher prevalence and incidences compared to endometrial CA. And women usually have a 2.6% life risk of developing this type of cancer, and peaks mostly in the 6th and the 7th decades of life, but some may develop this malignancy before even the age of 40. The median age is usually in the 7th decade of life, but some patients might be diagnosed between 50 to 59 years, that is between the 5th and the 6th decade of life. So estrogen plays a very key role in the development of endometrial cancer, and we'll see that this is one of the major pathways through which develops, and it is the major pathway through which most of the risk factors influence the development of the malignancy. And there is a noted declining incidence due to progesterone use in hormonal replacement therapy and low-dose estrogen combination birth control pills. So some of the risk factors which are implicated include late menopause, nulliparity, unopposed estrogen therapy, history of persistent anovulation, history of irregular and excessive premenopausal bleeding, obesity, diabetes, and hypertension, personal or family history of other associated malignancies such as breast, ovarian, and colorectal CA. Atypical endometrial hyperplasia, tamoxifen therapy, and radiation menopause. So we are going to look at each of these in detail in the preceding slides to see how they influence the development of the endometrial CA. So to start with estrogen, as we had mentioned before, if there is a persistent stimulation of the endometrium by high estrogen levels, then there will be an opposed proliferation of the endometrium, which can undergo malignant transformation, leading to development of endometrial CA. In terms of age, the mean age, median age is usually around 60 years of life, and about 10% of the women with postmenopausal bleeding have endometrial cancer. In terms of parity, nulliparity is associated with an increased risk of development of this malignancy, and late menopause as well. That is menopause that occurs beyond 52 years, increases the risk of getting endometrial CA. So obesity can significantly increase the risk of endometrial CA, and this is usually because of its action in increasing the levels of endogenous estrogen, and this occurs through its promotion of conversion of the precursor forms of estrogen, their conversion to estrogen. So it promotes the conversion of androstenedione to estrogen compounds, and mostly the estradiol form of estrogen. So high levels of this estradiol will then predispose an individual to developing malignancy. Nulliparity increases the risk of endometrial CA 2 or 3 times. And those with late menopause also have an increased risk. We had mentioned that. And also an ovulation can be as a result of an opposed estrogen. And that is how it leads to, it predisposes to endometrial cancer. Tamoxifen is weakly estrogenic, and it's an anti-estrogen and is used for treatment of breast cancer. So its association with increase in the risk is only when there is a prolonged use of the drug. So if it's used for a long time, then it leads to a weaker estrogenic effect and therefore leading to predisposing to endometrial CA. And actually, those who use combination oral contraceptives have a lesser risk of developing endometrial CA compared to those who don't take combination oral contraceptives, which are usually made up of the estrogen and progesterone combined pills. Cigarette smoking also confers decreased risk for development of endometrial CA. And this decrease in the risk occurs concurrently with body weight. So if you have higher body weight, or if you are heavier and you smoke, you're likely to have a lesser risk of developing endometrial CA. But the side effect of that is smoking is associated with other malignancies, such as lung cancer and other major health problems, such as cardiac disorders. So this does not mean that you are supposed to smoke to reduce the risk of getting endometrial cancer. Also, the risk of the malignancy increases with comorbidities, other comorbidities such as breast CA, colon CA, and ovarian cancers. So actually, for those who have breast cancer, have a 2 to 3 fold increase in the increased risk for developing an endometrial CA. And those who have hereditary non-polyposis colon CA, they also have an increased risk of developing this type of malignancy. Also, those who have family history of endometrial cancer, they tend to have an increased risk. And this is why it's important when you're taking the history from the patient, you're supposed to ask about a family history of the same malignancy. So phenotypic characteristics are used to divide the endometrial CA into 2 major types. So there is type 1 and type 2, which we are going to see. And these are dependent on the various risk factors that combine to lead to the development of the malignancy. So for example, in type 1 of endometrial carcinoma, women are usually obese with hyperlipidemia, signs of hyperestrogenism, uterine bleeding, infertility, and late onset menopause. While in type 2, endometrial CA, they don't have these predisposing factors. So this is how the endometrial CA is divided into 2 types, and these are the characteristics of either of the two, each of the 2 types. When it comes to classification, there are 3 major classes of endometrial CA, including endometrial hyperplasia and carcinoma in situ, and then the invasive form of the endometrial CA. So to start with the endometrial hyperplasia, this is basically the glandular hyperplasia of the endometrium, which is benign, but it has the potential to transform to become an endometrial carcinoma following the process of carcinogenesis. But patients might present with symptoms which are not clinically distinguishable from the endometrial CA. Further classification of endometrial hyperplasia is based on whether it's simple or complex, or whether it has atypia or doesn't have. So we can subdivide endometrial hyperplasia into hyperplasia with atypia and without atypia, and further subdivide each of those 2 categories into simple and complex. So starting with hyperplasia without atypia, so the major defining factor here is hyperplasia with crowding of glands in the stoma, and there is no clear atypia. So there are 2 types. We have the simple hyperplasia and the complex hyperplasia. So in simple hyperplasia, the glands are crystallically dilated and they have a Swiss cheese appearance on histology. So it is usually asymptomatic and incidental finding, mostly during hysterectomy, and it has a 1% chance of progressing to see cancer when not treated, and 80% of them might regress spontaneously. For complex hyperplasias, they have crowded appearance of the glands with very little intervening stroma. There can be epithelial stratification and mitotic activity, and if they are left untreated, there is an 83% chance that they will regress, and 3% chance of progression to malignancy. In hyperplasia with this had no atypia, so this is with atypia. So it can also be divided into simple and complex. So it is usually characterized histologically by endometrial glands, which are lined by enlarged cells with increased nuclear to cytoplasmic ratio. They are usually mostly considered pre-malignant, and they have patients with this type of hyperplasia have a higher chance of progression to malignancy. So progression occurs in 8% and 29%, 8% of the simple atypia and 29% of complex atypia. So here we can note that those with complex type of hyperplasia with atypia, they have a higher chance of progressing to endometrial cancer. The second type is carcinoma in situ, which is basically progression of the hyperplasia with more carcinogenesis to form carcinoma in situ, which is usually confined. It is distinguished from carcinoma by the presence of the intervening stroma between the abnormal glands. So that is the defining feature at histology that will help you classify it as a carcinoma in situ. So on the higher side, on the extreme side, we have the endometrial carcinoma, when that progression of differentiation continues, resulting in the eventual form of the invasive carcinoma. So the carcinoma is characterized by obvious hyperplasia and anaplasia of the glandular elements, and there is invasion of the underlying stroma, the myometrium, or the vascular spaces. So spread of the endometrial CA can take 4 pathways. So the first one is a direct extension, which is the most common form of the local extension beyond the uterus. Can also extend through lymphatic metastases, which accounts for its spread to the nearby lymph nodes, including the pelvic, para-aortic, and rarely inguinal lymph nodes. Can also spread through peritoneal implants after transtubal spread, and this one results in intraperitoneal implants, especially with uterine papillary serous carcinoma. Can also spread through hematogenous pathway, and this will be responsible for distant metastases to the lungs, to the liver, bone, and the brain. And there are 3 major histological subtypes of endometrial CA, including adenocarcinoma, carcinoma with squamous differentiation, and adenosquamous carcinoma. So we had already mentioned these 2 types when we were talking about the phenotypic characteristics that help distinguish endometrial CA into 2 types, and these are the 2 clinical types. So in terms of staging, there are different ways of staging, but mostly we use histological staging and the surgical staging, which follows the FIGO staging. So histological staging is usually divided into three. So we have class G1, class G2, and class 3G. So in G1, we have non-squamous or non.
Kioko, sorry I interrupt. Is there something like histological staging, or these are tumor grades?
Yeah, it's basically grading.
Yeah, this is grading. If you say
Grading,
staging,
grade 1, 2, 3.
Yeah.
Yeah, sorry, I will change that on the slide. So grade 1, we have non-squamous or non-modular solid growth pattern of 5% or less. In grade 2, we have non-squamous or non-modular solid growth pattern of 6 to 50%, and it's more than 50 in grade 3. So surgical staging is based on the abdominal exploration, pelvic washings, total hysterectomy with salpingo-oophorectomy, and selective pelvic and peri-aortic lymph node biopsies. So
Go back a bit. Abdominal exploration, like as if your colleagues ask you, what are you exploring? For what? How would you explain it?
I didn't check up on that. Could you please help?
Who among you checked on it? None of your colleagues? So abdominal exploration basically, just as the word says, involves exploring in a systematic manner, yeah, the solid organs or any other, all the visceral organs in the abdomen. So you come, you explore your mentum, yeah, you explore the colic gutters, you explore the the organs, liver, spleen, yeah, in a stepwise fashion to look at their involvement. Sindio?
Yes.
Yes, and pelvic washings. What is that? And what are they for? Yes, anyone can answer, not only the presenter. So some of these patients, you might enter and find ascitic fluid, isn't it? Like high volume ascites, low volume. So what you need to do is just sample that fluid for cytology. Sometimes if it's not there, you need to now infuse a normal saline and, you let it wash through the peritoneal cavity, and then you sample some of it for cytology. So total hysterectomy with salpingo-oophorectomy. Is this bilateral or unilateral? So you have to indicate, yeah?
Okay.
Isn't it the issue of lymph nodes is a debatable topic, yeah?
Okay.
Okay.
So in FIGO staging, we have 4 stages.
Which year?
For the
FIGO surgical staging. Which guideline did you use? 2018 or the ones which was previous to that?
2018.
Okay. Continue.
Yeah. So in stage 1, it can be divided into 3. So we have stage 1A, stage 1B, and stage 1C. So in 1A, we have tumor limited to the endometrium. 1B, invasion to less than 1/2 of the myometrium, and C, invasion to more than 1/2 of the myometrium. In stage 2, it's divided into 2. We have stage 2A and stage 2B. So in stage 2A, we have endocervical glandular involvement. only, and in stage 2B we have cervical stromal invasion. Stage 3 we have 3A, 3B, 3C. So in A, the tumor invades into the serosa of the corpus uteri without involvement of the adnexa. In 3B, there is involvement of the vagina with or without involvement of the parametrial tissue. In stage 3C, we have metastasis to pelvic or paraortic lymph nodes, in which if it can be divided further into two, in where C1 has positive pelvic nodes, and in C2 we have positive paraortic lymph nodes with or without positive pelvic lymph nodes. In stage 4, the tumor further extends to invade the surrounding organs, and because given the relation of the uterus to the pelvic organs, we can have involvement of the bladder anteriorly or the involvement of the bowel posteriorly. We can also have, so that is stage 4A, and in stage 4B, it's where now we have distant metastasis, mostly through the hematogenous spread to intra-abdominal or the inguinal lymph nodes. Yeah, and then so most patients will present with the earlier stages. So for example, stage 1 will account for about 75% of endometrial CS. And at this stage, there is an overally good prognosis in terms of management. So that is the introduction part. So I welcome the next presenter to take over the management.
Okay, so we'll move on to the management part. Are you able to see my screen?
Yes,
Are you
you
able
can
to
see.
see my screen? Okay, thank you. Thank you. So we'll move on to the clinical features in terms of presentation of the patient. History, most of them, about 75% come with postmenopausal bleeding. Remember that most of these patients are on their sixth decade of life. So they come with post-menopausal bleeding, and this abdominal bleeding usually occur in about 80%. And this is the most important warning sign of endometrial cancer. They can also come with abnormal vaginal discharge, which is after menopause. And then during premenopausal years, the bleeding is usually described as excessive flow. Remember, as Nicholas mentioned, you have like two types of patients. So you have your type 1 patient who is obese and is postmenopausal, and you have your type 2 patients who are usually more of African American, and they tend not to be obese and they are premenopausal. So when that patient comes to you, they usually complain of excessive flow at the time of menstruation. And then the bleeding can also be described as intramenstrual spotting, premenstrual or postmenstrual bleeding. As a presenting symptom, hemorrhage is usually rare, but about 20% of all your patients who come with postmenopausal bleeding, about 12 to 20% of all patients with postmenopausal bleeding usually have an underlying cancer, and 12 to 15% of these usually endometrial cancer, with the rest being either uterine sarcoma or cervical, vaginal, or ovarian carcinoma. So it is a cause of postmenopausal bleeding, and this usually increases with age, such that after the age of 80, the cancer is responsible for about 50 to 60% of cases of all postmenopausal bleeding. So apart from that, about 10% usually complain of lower abdominal cramps and also pain. And this is usually secondary to uterine contractions caused by detritus and also blood trapped behind the stenotic cervical os, that is postmenopausal. So if the uterine contents become infected, then the patient can develop an abscess, and they might also have signs and symptoms pointing towards sepsis. So on physical examination, pelvic examination findings may entirely be normal and might have no gross evidence of disease on the cervix, and more often than not, you have a normal sized uterus. So the cervix usually looks healthy, but you might have a purulent or offensive discharge that escapes from the external os. On bimanual examination, you might have a uterus that is either atrophic, normal, or maybe enlarged due to a spread of the tumor, or if the patient has an associated fibroid, then still can be the cause of the enlarged uterus. So the uterus is usually mobile unless in the late stages. Remember, most patients come early stage. And in this case, in the late stages, the uterus usually becomes fixed. Rectal examination to corroborate the bimanual exam findings, and you can still do your check for lymphadenopathy and also examine the breast. So in terms of investigation, vaginal ultrasonography usually has findings that can be suggestive of endometrial cancer. And these usually include an endometrial thickness of more than 4 millimeters. Some sources say 5 millimeters. Hyperechoic endometrium with irregular outline, increased vascularity with low vascular resistance, and intrauterine fluid. So in ultrasonography, if you find these features, then they're suggestive of a patient having endometrial CA. So a definitive diagnosis is through endometrial biopsy. You can still do dilatation and curettage, and hysteroscopically directed biopsy. And this is important in terms of direct visualization of the endometrium in order to take a biopsy. So examination with the patient under anesthesia may be necessary in patients who have a cervical os that is very stenotic. So anesthesia may also be required to perform dilatation for endometrial sampling. So you can still go ahead and do other imaging modalities, including CT and MRI to detect lymph node metastases and also myometrial imaging. So in differential diagnosis, so this is either a premenopausal or postmenopausal woman coming with bleeding. So the bleeding could be due to neoplasms, could be due to atrophic changes in the vagina, could be due to benign lesions, including polyps and also endometritis, or hormone replacement therapy. So it's just good to have those ones in mind whenever you're having such a patient. So in management, in terms of prevention, so remember, obesity is associated with increased or hyperestrogenic state. So watching weight can be sort of like a preventive measure. But remember that again, that is only for type 1 sort of like patients. You can restrict the use of estrogen after menopause in hysterectomized women. And if in case you're going to use estrogen for those patients, then you should try to do sort of like a cyclical administration of progesterone at the same time. You can also educate the patients on significance of irregular vaginal bleeding in the perimenopausal and postmenopausal period. So the secondary prevention, not routinely, we don't really do screening, but for high risk women, you might use it to detect premalignant or early carcinoma, which might be beneficial. So in terms of the treatment algorithm, so you have from your signs and symptoms, your examination, and the endometrial biopsy confirmation of a pathological diagnosis. So if you're having grade 1 endometrial histology, then you can do total abdominal hysterectomy with bilateral salpingo-oophorectomy. If you're having grade 2, grade 3 endometrioid histology, then you can do total abdominal hysterectomy plus bilateral salpingo-oophorectomy plus node dissection. And if on further surgical staging you have a patient with stage 1 disease, then you can go ahead and do brachytherapy for them. If they have stage 2 disease, you can do pelvic external beam radiation therapy or brachytherapy. And if they have stage 3 disease, you can do pelvic external beam radiation therapy plus or minus the nodes. If you're having a patient with the
What
serous,
is the presenter?
Sorry.
Jina ya presenter ni nani?
Oh, I'm Ian. I'm Water.
Yeah. So how do we approach treatment of endometrial cancer? Isn't it based on risk stratification generally? Yeah. So did you read about risk stratification? Because that is what will guide our treatment. You know, low risk, intermediate risk, and high risk. Yeah. So for low risk, which treatment do you give?
Okay, maybe I missed out on that. But in terms of if you're having a patient with grade 1 endometrial histology, which will be a low risk disease, then you can do a total abdominal hysterectomy plus bilateral salpingo-oophorectomy. But if you're having patients with,
you have to know the specific risks, so that those is what will determine treatment. Yeah.
Okay.
But generally, the treatment offered will be just surgery alone, and depending on the specification. That's why I'm saying it's important to know. Could be surgery alone, or it could be
surgery and chemo
alone after surgery and radiotherapy, or it could be surgery, radiotherapy, chemo. You know, so you have to know.
I get you.
As I have said, you can do check about low risk factors. Low risk factors, what are they? Intermediate risk, what is that? And high risk, who are those?
Okay.
Mostly based on histology, stage, and other pathological factors intrinsic to the tumor itself, like depth of myometrial invasion, lymphovascular space invasion. All those have to be what you consider. Yeah, it's not one model fits all. Yeah. Okay.
So thank you for that. So of course, treatment again, like Doc has said, surgery or radiation therapy. Preparative evaluation usually involves doing a full hemogram, postprandial sugar. Remember, you have these patients who are obese. You want to check the urea, creatinine, electrolytes, your liver and renal function tests. You want to do your EKG and X-ray because you're going to use anthracyclines, which might have cardiotoxic effects. Abdominopelvic ultrasonography for ascites, metastases, and also the other imaging options for extrauterine spread of the disease. So surgery usually involves explorative laparotomy with total abdominal hysterectomy, bilateral salpingo-oophorectomy, peritoneal cytology, pelvic and paraortic lymphadenectomy. But again, as Doc said, this depends on the risk stratification. So if you have intraperitoneal disease, then attempts are made to add surgical removal, and the staging is then determined based on the surgical pathological findings and the cytological results. So subsequent therapy usually depend on the surgical pathological findings of the operative procedure. So you can do chemotherapeutic agents, which are usually mainly we use doxorubicin and cisplatin for treatment of advanced or recurrent endometrial cancer. Other agents that can be used.
No. It's not the case. Where did you get these regimens from?
From the Kenya National Cancer Treatment Protocol, 2017.
According to recent studies, the regimen we use now with cisplatin and paclitaxel. Okay.
And paclitaxel.
Yes.
Okay. I'll rectify that. So use cisplatin plus paclitaxel. And then you can also use hormonal therapy, where you can use progesterone in treatment of recurrent endometrial carcinoma not amenable to irradiation or surgery. And you can use oral megestrol, parenteral, medroxyprogesterone, acetate suspension. You can also use tamoxifen, remember, but again, you don't want to use it long term because it has some weak estrogenic effects. So it can be used as in advanced or recurrent endometrial cancer at that dose.
That is a bit misleading.
Yeah.
Seeing here, your slide is a little misleading. So you either have progesterone or so tamoxifen, no. Okay. So
Hello,
I'll remove it.
hello.
Hello.
please.
Yes, can I make a comment?
Yes, please.
Yeah, that's why I said if you can read in the chat in the first session, I said all the slides should be forwarded to the moderator for moderation before you sambaza them to your other students.
Okay.
So
Sorry
make
about
sure that you forward those slides to Dr. Gitari. He goes through and makes the necessary amendments as
Okay.
per what we are using now, and then you share with your colleagues.
Okay.
Because most likely where you got that information is an outdated version, or there is something which is, that's why we have a moderator to make sure that that is the correct information you are sharing with your colleagues.
Okay. This must be the old.
And that goes to everybody who presents.
Yes. I'll take a couple of things. Okay. So I'm not sure if I should.
Again, this one touches, treatment is based on risk stratification, and I will include that in the slides which you will bring. I'll include that correction. Okay. So the criteria used to choose which patient you give further adjuvant treatment and which adjuvant treatment. Okay.
Okay. Okay. Thank you, Doc.
Continue
I'll
with the
just
recurrent. Yes.
So common sites for recurrence include the vagina and the pelvis. And you also have extrapelvic metastases, usually seen in the lungs, the liver, the brain, and the bones. Majority usually occur within 2 years of initial therapy. And radiation therapy is the choice for isolated recurrences.
Again, it's based on other several factors. Yeah.
Okay.
Yes. It's not a one size fits all, by the way. Yeah, so it depends with the previous treatment someone has received. For example, if I had received radiotherapy initially and I recur again, do you still proceed to offer me that?
No.
Yeah? If I had received surgery without radiotherapy initially, so you see, you will offer me radiotherapy.
Yes.
Yeah. Yes, and then also depending also on the stage and the treatment you gave initially for chemotherapy, to determine which chemotherapy you give. And then there's minimal cases where they can still have surgery in case of very local recurrences suitable for surgery. So they can have exenteration, though rarely performed.
Okay. Thank you for that. So prognosis depends on the stage and the grade. So 5-year survival rates are about 80 to 90% for stage 1, 67 to 77 for stage 2, 31 to 60 for stage 3, and 5 to 20 for stage 4. And of course, this depends on the age of diagnosis, the stage, the histological types. We talked about papillary serous and clear cell having poor prognosis compared to the typical adenocarcinomas. And then the histological grade with grade 3 having 5 times more risk for recurrence. And myometrial penetration and also lymphovascular space invasion, which again tie up with the stage of the disease. Extension to the cervix, tumor size, hormonal status, oncogene expression of the HER2 usually confirm poor prognosis. That is the end of the presentation, though there are several things that I'll need to think before sharing.
Yes, yeah, there came several issues, especially the management. I'm a bit concerned about that. It is very important to really have a close look on those risk factor stratification with grade management. But I will share the slides with you guys so that you check what is currently recommended.
Thank you. So if there are no additions, we can move on to ovarian cancer.
There was a Good evening, everyone. How are you?
Good
Is
evening.
the next? I think the next presentation is uterine corpus, isn't it? The sarcomas. Who's your class coordinator?
Zedekiah.
Hello, who's your class coordinator?
Zedekiah is.
Yes, so the next presentation, isn't it on uterine corpus, the sarcomas, the uterine sarcomas?
I think we were supposed to cover that, but we don't have a presentation on that.
And why is that so? Why don't you have a presentation on the sarcomas? Class coordinator, please answer and tell me why is it that you don't have a presentation on the uterine sarcomas?
Was it allocated?
Yes, it was allocated, but I don't know why they
No,
don't have a presentation.
I'm asking the class rep.
Ah, okay.
Yeah. Because probably they must have skipped out allocated one of the student, one of the students. So was it allocated so that somebody did not prepare, or it was missed out by mistake?
It was missed out by mistake, if I'm not wrong.
That's for a fact. Or you're guessing?
Sorry?
I'm asking him, is it for a fact that they missed it by mistake, or he's guessing? So if you don't have a class if you don't have presentation for sarcomas, the next one is what?
Ovarian carcinoma.
Ovarian carcinoma. So you have to find Dr. Fried later on and schedule a class the course of next week for that.
Okay.
Okay, thank you. I'll share my number with you. Yes, I'll share my number with you, with the class coordinator, and then we can schedule for a class this week or even next week is okay.
Okay, thank you, Doc. I think that will work. Sorry, I think we did not, we skipped that. We didn't see that. Thank you. I think I'll get the number.
Okay, that's fine. That's fine.
Yeah, just a comment. There were some questions on endometrial cancer in the chat box.
Okay, do you want us to address them now? They're a bit lengthy. I don't know, it will affect the time for the other presentations. Coordinator, how much time do you have? How many more presentations do you have left? And
I think we still have time. Ideally, we were to finish this class by around 8 p.m. But I think we're ahead of time, so I think we can address the questions.
okay, so they asked about the risk stratification. So
Dr. Gitari, just before you answer, you are meant to have the session up till what time? Because we have to be cognizant of the fact that some people reach saturation and some of our colleagues are fasting, so they need to go and break their fast. So the remaining, I propose up to 6:30 or 6 thereabout, then the rest can be done next week. That's my proposal.
Yes.
I
Thank you.
support the
Thank you.
proposal.
Yes.
So do we proceed ahead with the questions or we do the next presentation?
You could answer the questions, then they move on to the next presentation, which should be the last for the day. Then they give time.
So I think
our Muslim brothers to go and break their fast. That's unfair to just say until forever. That's my thinking, but the decision will be on the coordinator.
yes, that's okay, though. That's okay.
Okay, so there are several risk factors. So we have, can you hear me all? Yes, so we have, so low risk factors. Patient, the first one is a patient with cervical endometrial, cancer without high risk histology. So we know all non-endometrioid are high risk histologies. So those ones are high risk already. So histology of grade 1 or 2, and endometrial cancer limited to the endometrium, invading less than half of the myometrium, that is less than 50%, and also no lymphovascular invasion. So for these patients, we offer them, surgical staging, and there is no need for adjuvant treatment, further adjuvant treatment. And then we have patients with intermediate risk factors. So also these are patients without high risk histology, with grade 1 or 2 invading less than 50% of the myometrium, but with lymphovascular space invasion, or grade 1 or 2 invading more than 50% of the myometrium, or demonstrating occult cervical stromal invasion, or grade 3 invading less than 50% of the myometrium. So these patients are further subdivided into another one, which have high risk intermediate factors. Yeah. So the high risk intermediate risk factors, patients could be one with those with the lower uterine segment invasion and deep myometrial stromal invasion, and they have lymphovascular space invasion. So these patients are offered postoperative radiotherapy, and the postoperative radiotherapy modality of choice is vaginal brachytherapy. So that is how they are treated. And then you have the patients with high risk. High risk patients are those who have stage 3 or higher, and regardless of histological grade. So those also who have serous or clear said, or the ones we had said the histologies apart from endometrioid, those ones. And then we have grade 3, deeply invasive endometrium. And those patients are offered adjuvant chemotherapy. Okay. So I don't know if that is clear. I'll need to send the summary of that. I know you can't grasp it all at once. It's a bit detailed, but basically those are the modalities. And then for advanced cancer, after surgery, they offer for advanced and recurrent, yeah. Okay, for advanced, first of all, you offer them chemotherapy. And the regimen of choice, as we have said, is cisplatin and carboplatin as a first line. Okay, and then for the recurrent setting, the patients are also offered a treatment depending on the type of treatment they received before. So if someone had received radiotherapy initially, and then recurrence, we talked about local recurrence or the ones who have already have disease outside the pelvis, that is with metastatic disease. So those with very small specific tumors can be offered treatment, but that is a small subset if they had initial surgery before. or even radiotherapy. And then if they had surgery without radiotherapy, they can be offered radiotherapy. And those who don't qualify for either of that, they are offered chemotherapy. So among the chemotherapy agents choice, again, it's that, with or without addition of targeted therapy. That is just treatment in a nutshell. Targeted and hormonal therapy, sorry. Any other questions? Coordinator, questions? I don't know if I've addressed the ones which were there satisfactorily.
Just a follow-up question on the criteria. So in my reading, I came across various risk stratification models, and I wonder which one is used, because, for example, there is Mayo criteria, Mayo modified criteria, GOG criteria, ESMO criteria. So which of those should we use?
Basically, we are using the GOG criteria.
Okay.
Okay, thank you, Doc, for the clarification, and also for answering the questions. If there are no more questions, I guess we can move on to ovarian. Okay, please confirm that you can see the slides.
Yes.
Yes, you can see the slide.
Thank you. So we'll be going through ovarian cancer. So on epidemiology, this is the second most common gynecological malignancy and a major cause of death from gynecological cancers. In the UK, approximately 7,000 new cases and 4,000 deaths from ovarian cancer every year. So it is the sixth most common cancer in women worldwide. And the rates of ovarian cancer in East Africa are among the lowest in the world. Lifetime risk is about 1.4%, that is 1 in 70. And the mean age of presentation is 64 years, although you can have presentation among premenopausal patients. So it is more prevalent in higher income nations. There is a variation in terms of ethnicity, with women having a higher incidence compared to Asian women, that is 14 to 10. And it's rare in young women, at only 3% of ovarian cancers occur in women under the age of 35. So when detected earlier, it has an excellent prognosis, although screening has not been shown to be effective, and there are few advances in terms of development of targeted treatments for advanced. So pathogenetic mechanisms, or more of theories. So there is the incessant ovarian theory, ovulation theory, sorry, which basically try to explain the development of ovarian cancer as a result of repeated trauma during ovulation, which results into risk of genetic aberrations during that process. And then you have the gonadotropin theory, which sort of tries to explain ovarian cancer development as a result of persistent stimulation with epithelial proliferation and subsequent increased mitotic activity. In terms of risk factor, so 10% of ovarian cancers occur as a result of genetic predisposition, And this is usually patients who have a familial history of either BRCA1 or BRCA2 gene mutations. This usually predispose patients to both ovarian and breast cancers, and also the familial history of hereditary non-polyposis colorectal carcinoma, which predispose them to both ovarian and also colon cancer. 90% are more of like unknown, but you have risk factors such as age. And of course, you say that median age of 64 years, nulliparity, early menarche, and late menopause, which tend to tie with the theories in terms of gonadotropin stimulation, and also in terms of the repeated sort of like injury that occurs during ovulation. Also exposure to talc, but this is in the back in the day, which resulted into ovarian cancer, but not commonly used these days. You also have, though not really sort of like proven, but milk products and saturated animal fat as being predisposing factors or risk factors for development of ovarian cancer. In terms of classification, so you have the epithelial tumors, you have the sex-cord stromal tumors, and the germ cell tumors. The epithelial tumors usually involve 5 subtypes, including the serous, the mucinous, the clear cell, the endometrioid, and endometrioid, and then the sex cord, including the granulosa, the Sertoli cell, and the germ cell, including the dysgerminomas, the endodermal sinus yolk sac tumors, the teratomas, and the choriocarcinomas, which are more of non-gestational. But you can also have metastatic tumors to the ovary, mostly from the GI, which include the Krukenberg tumors. So we'll go to the individual subtypes. So germ cell tumors are. Yes.
Can I interrupt? Yeah, can you go back to the risk?
Okay. Okay.
Okay.
Yes.
Yeah. Yeah, when you are talking of risk factors, you also have to talk about the protective risk, the protective factors to ovarian cancer, like parity. Increased parity has been shown to reduce the risk.
Yes.
Breastfeeding, use of oral contraceptives, especially the combined oral contraceptives. So use of it for more than 5 years has been found to be protective. Then in relation to the genetic factors, as you had earlier said, that those who have BRCA1 and BRCA2 gene mutations have, it is a 10 to 15% risk of developing ovarian cancer. So risk reduction surgeries like salpingo-oophorectomy, for those where genetic testing has been done, has been found to reduce the risk of getting what? Ovarian cancer. Then also in terms of pathogenesis, you had talked of the menstrual theory and the gonadotropin, but there's also the molecular theory, whereby molecular theory of pathogenesis, whereby it's divided into type 1 and type 2. Type 1 is where by the inclusion cysts from either menstrual blood or endometrial tissues undergoing mutation, hence resulting into tumors which resemble the clear cell, and then at the same time the endometrioid, ovarian cancers. Then type 2, which is also called sporadic molecular theory, which talks about ovarian theory occurring sporadically, which is seen in the serous type of epithelial ovarian cancers. Thank you. You can go ahead.
Thank you for that. So germ cell tumors, which account for 10% of the ovarian tumors, and the most common presenting symptoms among these patients usually have pelvic mass, and in cases where the ovary undergoes torsion, that they can present with more of like an acute abdomen presentation. And most of the germ cell tumors are usually stage 1, and they spread through lymphatics or hematogenous. So among the germ cell tumors, these geminomas are the most common, accounting for about 50% of all germ cell tumors, and they usually occur bilaterally in about 20%, and they usually occasionally secrete human chorionic gonadotropin. For the endodermal sinus yolk sac tumors, that's the second most common after the these geminomas, and they usually account for about 15% of the total. They are rarely bilateral, so mostly unilateral, and usually secrete alpha-fetoprotein. They present with large solid mass that often causes acute symptoms with torsion or rupture. So you also have immature teratomas or teratomas in general. So teratomas can either be mature or immature, the mature being the benign ones, and those are usually about 90% of the teratomas, with the immature teratomas accounting for about 1%, but they account for about 15 to 20% of malignant germ cell tumors. So about 1/3 of teratomas produce alpha-fetoprotein, and they can usually have malignant transformation, transforming into squamous cell carcinomas. So non-gestational karyocarcinomas are rare, but they usually present in young girls with irregular bleeding, and usually have high levels of human chorionic gonadotropin, but are very chemosensitive, just like the non-gestational karyocarcinomas. So we talked about the benign and the malignant forms. For sex-cord stromal tumors, so these account for about 10% of the ovarian tumors, and 90% are usually functional, with either producing estrogen or androgens. So the estrogen producing are usually the granulosa cell, the theca, or the Sertoli cell, and the androgen producing are usually the Sertoli Leydig or the steroid cells, resulting into either precocious puberty for the estrogen producing, abnormal menstrual bleeding, at increased incidence or increased risk of endometrial cancer for the estrogen producing functional sex-cord stromal tumors. So the peak incidence is usually around the age of menopause, although you can have juvenile granulosa cell presenting in girls under the age of 10, causing precocious puberty. Granulosa cell are the most common subtype of the sex cord, accounting for about 70%. So for the epithelial tumors, about 80 to 85% have 5 different histological subtypes. Approximately 10% are usually classified. Yes, Doc?
Can I interrupt a bit?
Yes.
You could go back to the slide before. Yes, about the sex cord stromal.
Yes.
Yes, there. Yes, there. Maybe what I can add is they are divided as there are those pure sex cord tumors. Then there are those the stromal, pure stromal tumors. Then we have both sex cord and stromal tumors. So the sex cord stromal tumors are the granulosa, the pure sex cord tumors are the granulosa cell, the granulosa cell tumors, which are divided into the adult and the juvenile. Here you mentioned about the juvenile. Yes, they are normally in younger age, but the adult granulosa cell tumors can occur at a later age, pre or perimenopausal period, and they can occur at this, they can occur in women who are who are pregnant. So a pregnant woman with an ovarian mass, then a sex cord granulosa cell tumor, most likely adult granulosa cell tumor is one of the what? One of the diagnoses. Then the stromal tumors include things like the tecomas and the fibromas, which are normally they are not hormone producing. Are we together? Yes. Then the mix that is both sex cord and stromal, we have the Sertoli Leydig cell tumors. They are hormone producing and they present with the, normally they present at early age, and one of the most common presenting signs are the precocious puberty. And normally what happens is that in those who present at early age, the prognosis is much better than those who present in late age, because maybe a young girl of 8 years who presents with vaginal bleeding is more of concern than somebody who is in 40s and having maybe intermenstrual bleeding. So people tend to take this young girl as a serious issue than an adult. So that is why there is attention drawn to it, and then their prognosis tends to be much what? Better than those who are adult. I hope there's somewhere where you will talk about the tumor markers which are used in monitoring those who have sex cord stromal tumors. We have already gone past the germ cell. Is there where
yes,
you will talk about the tumor markers?
Yes.
Investigations and follow-up, eh?
Yes.
Okay, you can go ahead.
Okay. So we'll move on to the epithelial tumors, accounting for about 80 to 85% of the ovarian tumors. So usually have 5 different histological subtypes, with 10% being borderline ovarian tumors. So these are tumors which are well differentiated with some features of malignancy, including cellular atypia and pleomorphism, but they don't invade the basement membrane. So they tend to spread to the peritoneum, momentum, but often they don't recur following initial surgery. So majority of the borderline tumors are usually serous tumors, but you can also have mucinous tumors, which can arise from appendiceal carcinomas of low malignant potential, and they can also be associated with pseudomyxoma peritoneae. So for high-grade serous carcinoma, they account for around 75% of all the epithelial ovarian cancers, and mucinous and endometrioid are less common, accounting for 10%, followed by the clear cell carcinoma. So high-grade serous tumors are usually characterized histologically by samoma bodies, which are just rings of calcification, while mucinous are usually they are multiloculated, and they're usually associated with pseudomyxoma peritoneae, which is just an accumulation of mucin within the peritoneal cavity. And then you have endometrial carcinomas, which usually have a similar histological appearance as endometrial cancer, and they account for about 10% of cases. So they tend to be well differentiated and associated with better survival than the high-grade serous carcinomas. For the clear cell, they can also arise from endometriosis and are characterized histologically by clear cells, much like the renal cancers. So in summary, so you have your serous, which tend to be bit aggressive, the endometrioid, which are good, mostly, especially if they're confined to the ovaries or stage 1 disease, stage A, stage 1 disease. Mucinous, if they're confined, they can have a good prognosis, and the clear cell, which tend to be aggressive. So in terms of serous, though we talked about a bit, so often bilateral, and they're characterized by the samoma bodies. And then the mucinous, which are characterized by mucin-producing glands, usually unilateral, and they have the pseudomyxoma peritoneae, which are accumulation of mucin in the abdominal cavity following leakage from the neoplasm. For endometrioid, they tend to be unilateral, and they're often hemorrhagic, they're morphologically identical to the endometrial cancer. And then for the clear cell, they tend to be unilateral, solid cystic masses. They can have hemorrhage if there is residual endometriosis. And morphology at the time of, in most time, is usually identical to the endometrial clear cell carcinoma. So in terms of the diagnostic algorithm for ovarian cancer, though we'll go into detail of what all this sort of like entail. So you have your suggestive history, either they're premenopausal or postmenopausal, and then suggestive physical examination if you're having a pelvic mass, an abdominal mass or ascites. And then you go ahead with your investigations, including the abdominal pelvic ultrasound, your tumor markers, and biopsy, though not routinely done. And then you calculate your risk for malignancy index. If the RMI is more than 200 or biopsy confirmed, then you tend to think more that the patient has an epithelial tumor. If they have increased tumor markers, including alpha fetoprotein, LDH, and beta HCG, then they tend to be more likely to be a germ cell tumor. And if you have a low risk of malignancy index, or the tumor markers are low or within normal range, then you start thinking of other causes such as metastatic tumor to the ovary. You think of TB, or you think of sex-cord stromal tumors. So in terms of the history, so these patients usually have very non-specific history. They can come with a variety of symptoms ranging from bloating, abdominal distension, discomfort, pressure on the bladder, rectum, constipation, vaginal bleeding, indigestion, shortness of breath, and also abdominal mass, weight loss, and early satiety. So there is no specific symptomatology that they come with a wide range of symptoms. In terms of signs that you can elicit, they usually have, there are no definite symptoms, as I said. They can either go into like a surgical or an internal medicine problem like picture. They can have vague abdominal discomfort, urinary frequency. They can have pelvic pressure or mass in the lower abdomen, So a study done in Kenyatta National Hospital, the most common presenting complaint was abdominal swelling, followed by a combination of abdominal swelling and pain, which occurred in about 15% of patients, abdominal pain in about 8.3%, vaginal bleeding in 5%, and others in 1.7%. So postmenopausal woman with abdominal swelling and other vague symptoms, you start thinking more of like an ovarian tumor. In terms of your physical examination, so abdominal examination, so you try to elicit if the mass is a pelvic mass or if it's an abdominal mass. So of course, this involves doing a bimanual examination, and you tend to check if the mass is ovarian, or if it's intrauterine, or if it is an abdominal mass. And then you can check for ascites. You can do your shifting dullness, and also the to elicit ascites. And then you can do your respiratory exam if they're having pleural effusion, and then abdominal mass or bowel obstruction. You can still check for those. So in terms of ultrasonographic findings, and also basically clinical findings, if you're having a unilateral mass, you tend to think that it's more likely to be benign compared to if you're having bilateral, which in most cases are usually malignant. If you're having a cystic mass, it's tend to be benign in most cases. If it's solid, it's tend to be more malignant. If it's mobile, more benign. Fixed, more malignant. Irregular surface, more malignant. Smooth surface tend to be benign. If you're having a patient with ascites plus rapid growth, you're thinking more of like a malignant process. So some of the warning signs that you should, warning symptoms the patient can come with include the abdominal bloating, pelvic pain, bladder bowel symptoms, irregular vaginal bleeding, and also constitutional symptoms. So in terms of diagnosis, so you tend to do your baseline investigations. If they've been having this long-term vaginal bleeding, then you should do your CBC to check if they're having anemia uncorrected. You should check your LFTs and also UVCs. You should also check lactate dehydrogenase, which tend to be higher in patients with germ cell tumors. So pelvic ultrasound, and we'll talk about the features that you're looking for in a pelvic ultrasound. Both you can do transabdominal, transvaginal. So you're looking at, if I may just move, you're looking for multilocularity, you're looking for presence of solid areas, bilaterality, and then the presence of ascites and any evidence of metastasis. And this will be used in the risk malignancy index, which has 3 components. So ultrasonography findings. So you score either 1 or 3 based on these components. So you're looking for multilocularity, bilaterality, solid components, ascites, or evidence of metastasis. And for each of those factors, you score a point. If they have a score of 0 or 1, then you use 1. If they have a score between 2 and 5, then you use 3. And then for their menopausal state, so if they're postmenopausal, you use 3. If they're premenopausal, you use 1. And then CA 125 also, and then you calculate. So you multiply your value for you and value for the menopausal state and the value for the CA 125. If it's more than 200, then you should have them on gynecological referral. So MRI and CT can be used as part of the metastasis scan. And basically you're looking for, if you can't really evaluate the origin of the mass, or you can't really tell if it's clearly arising for the ovary. And also if you want to check for metastases to the omentum, the liver, the lung, you can still do these 2 imaging modalities. For tumor markers, so epithelial ovarian tumors tend to have elevated CA125, and this is usually in up to 80% of malignant tumors. But the specificity and the positivity predictive value depends on the menopausal state of the patient. So if it's postmenopausal woman, then you tend to think that it could be an epithelial ovarian tumor. But in the cases where they are premenopausal, then you start, there are several other benign factors that could result into a rise in CA125. For sex-chromosomal tumors, granulosa cells, you can still check for inhibition. So in terms of other causes of elevated CA125, which are not associated with ovarian cancer, and this is mainly in premenopausal states. So you have benign gynecological conditions like endometriosis, uterine fibroids, menstruation, vibrant fibroma, pelvic inflammatory disease, previous hysterectomies, benign oncological, non-gynecological causes like pain, liver cirrhosis, lung disease, obesity, tuberculosis, and other malignancies like lung cancer, pancreatic cancer, breast cancer. All this can result into elevated CA125, particularly in the premenopausal state. So in terms of the tumor markers for the germ cell tumors, so if you are having dysteminoma, they usually have elevated lactate dehydrogenase and also the beta HCG. For the yolk sac tumor, they tend to have elevated alpha fetoprotein. For the immature teratoma, they tend to have elevated alpha fetoprotein, lactate dehydrogenase, and also the CA125. For choriocarcinoma, this is non-gestational, and even gestational, they tend to have elevated beta HCG. And for the embryonal, they tend to have elevated AFP and also the beta HCG. In terms of diagnosis, so not recommend, we don't do non-invasive biopsy. It's not really recommended because of risk of upstaging the cancer. But usually have intra-op staging, which is recommended for diagnosis and should be utilized in patients with a high probability of having a malignant ovarian mass. And so that is after calculating the risk for malignancy index. So if malignancy is found, then it can be staged, and also you do cytoreductive surgery. So other tests that you can do, you can still do paracentesis, and you can do cytology on the acidic fluid. Although when you're doing intra-op, you can still collect peritoneal fluid for cytology. Pleural effusion chest X-ray to actually evaluate for pleural effusion, and also colonoscopy just to make sure that the tumor has not spread to the colon or to rule out primary colon cancer. So pattern of spread. So mostly you have spread into the peritoneal cavity. And the cells usually follow the normal circulation of peritoneal fluid from the right paracolic gutter to the right hemidiaphragm, but any peritoneal surface can be involved. Mentum is a very common site of involvement. We also have lymphatic spread, and this is usually to the pelvic and para-aortic nodes, and also the inguinal nodes can also be involved, but less common. So in terms of the staging, so you have stage 1 to 4. So stage 1A is limited to the one ovary. The capsule is intact. There is no tumor on the surface, and you have a negative peritoneal wash. And
interrupt?
Yes.
Just back to the last slide. Yes, I think you missed the hematological.
Yeah, hematological spread.
Hematological spread to the liver and the lungs. Because that helps you in the staging. Yeah?
Thank you for that.
Okay. Proceed.
Okay, so in terms of the staging, so stage 1A limited to one ovary, the capsule is intact. There is though this is according to figure classification, sorry, figure staging. Stage 1B involves both ovaries. Otherwise, it has the same features as 1A. And then 1C, either limited to one or both ovaries, but you have 1C1 where there is surgical spillage, and then 1C2 where there is capsule rupture before surgery or tumor on the ovarian surface, and then 1C3 where you have malignant cells in their ascites or peritoneal wash. And then stage 2, which usually involve both one or both ovaries with pelvic extension, with the 2A being extension and or implant on the uterus or the fallopian tubes, and then 2B being extension to other pelvic intraperitoneal tissue. And then for stage 3, so you have stage 3A, where you have positive retroperitoneal nodes or microscopic metastasis beyond the pelvis. And then stage 3B, where there are more macroscopic peritoneal metastasis, but less than 2 centimeters. But you also have positive, also either or not positive retroperitoneal lymph nodes, including extension to the capsule of the liver and spleen or spleen. And then stage 3C, where you have macroscopic extrapelvic peritoneal metastases, usually more than 2 centimeters, with or without retroperitoneal nodes, and include extension to the capsule of the liver or spleen. And then for the stage 4, which usually are distant metastases, and this is stage 4A, where you have a positive cytology on the pleural effusion, and then stage 4B, where you have hepatic, endosplenic, parenchymal metastases to extra-abdominal organs, including the inguinal nodes and the lymph nodes outside the abdominal. So in terms of treatment of the epithelial ovarian cancer.
Can I interrupt?
Yes, Doc.
Hello?
Yes.
Yes, back to the staging. Yeah, okay. This is figure 2014. What you are presenting is figure 2014.
Figure 2014, okay.
This is figure 2014. But there's figure 20. There's figure 2018.
Figure 20, okay.
So you go back and look at figure 2018, which is a little bit different from this.
Okay.
So take note of it. Yeah.
Okay, so I'll change that to figure 2018.
Yeah, go and look for figure 2018, which is a bit different.
Okay. So in terms of the treatment algorithm, so If the patient is fit for surgery and you can do complete resection, if they have early disease, particularly stage 1A, grade 1 or stage 1A to B grade 1, then you can just observe the patient. But if you're having advanced stage disease, then you have to do a debulking surgery. And once they are optimally debulked, then you do 6 cycles of carbotaxel. If the patient is not fit for surgery for one reason or the other, or there is a reduced likelihood that you'll do complete resection, then you can start with neoadjuvant chemo. And this is also important in terms of finding out if the patient will be platinum resistant. So you can start with neoadjuvant chemo, and then you do interval debulking, and then you continue with the adjuvant chemo. So in terms of chemotherapy, so you can use adjuvant therapy only after you've done the debulking surgery. And for advanced disease, all patients after initial cytoreductive surgery, you actually start them on the adjuvant chemotherapy. So the regimens that I use are the carbotaxel. So a combination of carboplatin and paclitaxel. The taxanes are the mainstay and preferred first-line regimen. But you can also use a combination of carboplatin, paclitaxel, and bevacizumab, or 5-fluorouracil and oxaliplatin. The routes of administration of the chemotherapy include intravenous, intraperitoneal, and also targeted molecular therapy. So this is indications for targeted molecular therapy. If you're having BRCA1 or BRCA2 positive diseases, if you're having maintenance therapy after surgical debulking and chemotherapy. So the target agents are the polymerase inhibitors. So you can use olaparib, niraparib, veliparib, and basically they actually tend to target the polymerase inhibitors. And then for radiation therapy, it's not routinely kind of like part of the treatment. So it's not preferred modality for ovarian cancer. And it's reserved for patients who have symptomatic treatment. So it's reserved as treatment for recurrent or metastatic disease, although you can still use chemotherapy for recurrent. So in terms of surgery, so it's used to obtain both pathological specimen and also to evaluate for extension of the cancer spread. Involves doing a peritoneal sampling for cytology, hysterectomy with bilateral salpingo-oophorectomy, pelvic and paraortic node dissection, and also omentectomy. So in surgical debulking, what you want to do is to have residual disease of less than 1 centimeter, and this usually kind of defines optimal debulking. So the sites that you should inspect while intra-op include the right and the left and the diaphragm, the liver, the gallbladder, the stomach, the spleen, the right and left kidneys, the right and left paracolic gutters, the small bowel and the mesentery, the appendix, the ascending and the transverse, the ascending transverse descending up the sigmoid colon, the omentum, the pelvic and paraortic lymph nodes, the uterus, the tubes, the ovaries, the bladder, and also the cul-de-sac. So the debulking surgery usually involves removal of all gross tumor at the initial operation. So it is usually a very intensive surgical effort. So it requires intensive surgical efforts and include removal of segments of the bowel, liver not so much because of increased risk of intra-op bleeding, but you can do away with the capsule, and then splenectomy, peritoneal stripping, and diaphragmatic resection. So the outcomes the major prognostic factors include the stage of presentation, the optimal debulking of the advanced stage, and also the tumor biology in terms of chemosensitivity, because again, you can have tumors that are platinum resistant, the histological subtypes and the grades. So most of the advanced tumors have poor 5-year survival rate, and patients tend to live longer due to advances that we've had in surgery and also chemotherapy. So of course, optimal and non-optimal, we talked about optimal being less than 0.5 to 1 centimeter of tumor left, and suboptimal being more than 1 centimeter of tumor left after maximal debulking. So in terms of chemotherapy regimens, so first line is the carbotaxel, but you can also use the platinum analog plus cyclophosphamide. So it's a 3-weekly 6-cycle administration. If you're having recurrent or metastatic disease, this usually depends on when the patient presents with the recurrence. So if it's within 6 months, then you tend to use other agents. So you tend to use pegylated doxorubicin as the second line. But if you're having recurrence after more than 6 months after 6 months, then you can still use the platinum analogs that you use initially as the first line. You can also use bevacizumab in combination with chemotherapy in metastatic disease. For follow-up and surveillance, so you always do 3 monthly for 2 years, and then 6 monthly for 6 years for 3 years. And during these follow-ups, what you're doing is you're checking for any patient presenting with new symptoms or recurring symptoms. And then you're also checking your CA-125. The level should be decreasing after the chemo and the surgery. You can still do CT and PET scan to evaluate for any recurrence, especially if you're using the PET CT. So intraperitoneal chemotherapy, this is usually delivered using a subcutaneous port. And the advantages is that you have higher concentrations of the drug and a longer duration of exposure. But the problem with it is that you tend to have increased adverse side effects compared to just giving IV. And also fewer patients tend to complete the cycles when they're given intraperitoneal chemo. So the side effects that you are anticipating include nausea and vomiting, peritonitis, bowel injury, and the catheter can be blocked or can leak, and also cumbersome administration. On your adjuvant chemo, so this is usually kind of like reserved for patients who have who the initial surgery might require might need to be aggressive, and they also have like poor performance status, or they have several medical comorbidities, or if they have extensive disease that preclude the optimal debulking, including liver, parenchymal, and pulmonary metastases, massive ascites, then you can start them on your adjuvant chemo. And these will optimize cytoreduction and also the size of residual disease. So this decreases also surgical morbidity and mortality, and also identify patients with platinum resistant disease. We always do 3 courses of platinum-based chemotherapy, followed by delayed surgery in all patients with a response or stable disease. Then after that, you can also do another 3 courses of platinum-based chemo. So for follow-up, we talked about the serial physical examination, the CA-125 levels, and there is no consensus on the CA-125 post-treatment, but you do your follow-up every 3 months for the first 2 years and every 6 months for the next. So long-term management issues, most patients will eventually have intraperitoneal progression of the disease, and this can lead to other issues such as ascites and also bowel obstruction. And so these result into more of like palliative management of patients and improving their quality of life. So in terms of prevention or screening, Doc already mentioned, you tend to avoid the risk factors, including the combined oral contraceptives, childbearing, prophylactic procedures like tubal ligation, prophylactic surgery for high-risk women, but there is no good screening test for the general population. For high-risk women, women who are in families where there is BRCA1 or BRCA2 mutations, you can do ultravaginal ultrasounds 6 monthly, plus or minus CA-125. And because they have BRCA mutations, you should also include mammography for them. And then colonoscopy and endometrial biopsy, particularly with the hereditary non-polyposis colorectal carcinoma. And prophylactic oophorectomy once they completed childbearing. In terms of prognosis, so the more advanced the stage, then the poorer the prognosis. With stage 1A, stage 1 A having a 5-year survival of up to 84%, and stage 4 having a survival rate of about 14%. These are my references. That is the end of the presentation.
Yes, thank you for nice presentation. Are there any additions from your colleagues before I comment? Is there anything?
Sorry. I forgot to mention. So in cases where you have ovarian germ cell tumors, then the chemotherapy regimens tend to be more of BEP, which is a combination of bleomycin, etoposide, and cisplatin. Or you can use EP, which is a combination of etoposide and cisplatin, instead of the carbotaxel, the carbotaxel which you use in the epithelial. So you tend to use BEP and EP.
Okay. From your colleagues, any additions or subtractions? If there are no other additions, what I wanted to add is one about the mucinous ovarian cancers. About 80%, 75 to 80% are metastases from gastrointestinal tract. That is either from rectum, pancreas, or from the stomach. And as you're investigating, you need to find out where the cause is. Is the primary source the ovary, or it is from the GI? Is that okay?
Yes.
And there are these tumor markers which we use to differentiate between primary mucinous ovarian cancer from metastatic ovarian cancer.
Yes.
Morphologically, intra-op, normally the primaries tend to be bilateral and they are bigger in size, while the metastatic tend to be smaller and they are normally what? Unilateral, not bilateral. And then at the time of diagnosis, you see a lot of adhesions or peritoneal carcinomatosis. So it tends to guide you on where the source of the primary site is. Then if it is mucinous ovarian cancer, then you use cytokeratin. We call it CK. I think you have seen it. CK7 and CK20 are used to differentiate between the two. In primary ovarian cancers, CK7 stain diffusely strong, while the CK20 stains diffusely positive, while the CK20 stains diffusely what? Negative, if it is primary ovarian. But if it is metastatic, then CK20 would stain diffusely what? Positive, while CK7 will stain diffusely what? Negative. Then we have other tumor markers like PAX, PAX8, PAX8, which also stains diffusely positive for metastatic mucinous ovarian what? Cancer, meaning that the origin is from the GI. Are we together?
Yes.
Then there's CDX2. CDX2 also stains diffusely positive for metastatic ovarian what? Cancer, meaning that the site is from gastrointestinal tract. Is that okay? And this now brings us to the chemotherapeutic agents we use. If it is primary mucinous ovarian cancer, we use carboplatin and paclitaxel. Are we together?
Yes.
But if it is a metastatic mucinous ovarian cancer, then we use a GI chemotherapeutic what? Regimens. And one of them is oxaliplatin and 5-fluorouracil. Are we together? That is given as intravenous, but the commonest we have at our clinic here is oxaliplatin plus cabecitabine. Are we together?
Yes.
Yes. So you need to go and check that in terms of what? Ovarian, mucinous ovarian what cancer. We have to differentiate clearly. Then the germ cell, you had said we use bleomycin, etoposide, and cisplatin. And we have to know about especially the side effect of bleomycin, the lung pulmonary toxicity. Yes. And then also for the sex cord stromal tumors, we also use BEP. Yeah? So that is where the difference is. Then the other thing is that rarely do we use intraperitoneal what? Chemotherapy. Yeah, but what is currently being used in the developed world is what we call hyperthermic intraperitoneal chemotherapy. Here, the chemotherapy, the drug is heated, then after operation, it is infused. You put drains to let the drug into the peritoneal what? Cavity. Then this drug drains out through another outlet. And a patient can be kept on that for about 48 hours. And it has been shown to have very good response in terms of those patients who have got extensive disease, that is stage 3 and stage 4, where you are not able to do optimal debulking what? Debulking surgery. Are we together?
Yes, we are.
Okay, those are the additions I wanted to make. I don't know whether you have questions for me or for Dr. Itsura about ovarian, fallopian tube, and peritoneal cancers. Your question is, why should we hit the chemotherapeutic agent? Hello?
Yes.
To be sincere, I'm not also what? I'm not also sure about it. But the heating is not going to be above body temperature. It should be something which is lukewarm as you are administering it. I'm not sure why they are what? Why they hit the chemotherapeutic what? Drug before administering it.
Thank you.
Another question? Victor, do you have any question?
No, I'm okay.
You okay? What about Tabitha?
I have no question.
Okay, what about Victor?
No question at the moment.
Ronald?
No question.
Everything well understood? Hilal?
No question, Doc. Thank you
Hilal
for
is-
the comment.
Isaac? Sharon?
No question, Doc.
So if there are no questions, can we go to break hour first?
Yes, please.
Yes. Thank you, Doc.
Thank you. See you.
Thank you.
Okay, thank you.
See you.